list, I would say, because many people are getting panicky about the so all delegates to please don't panic. If you have any problem, just WhatsApp message us instead of alert them. We are message and to you in difficult whichever you are having. So you know my number, you know the Anjali's number, you know the number, because we have been sending these numbers to you in all our past emails. So you can and you should actually WhatsApp instead of calling. That's the first instruction. I hope you have all received the recordings of previous sessions. If any of you have not received it, please do feel free to communicate us again by texting.
I think Dr. Meenakshi madam is busy in another conference, so her voice was not clear. Let me just repeat her words. If somebody is not receiving a link, please don't get panic. Just send a message to me or to her on our WhatsApp number rather than calling us, because we all are practicing doctors and we all are surgeons. I'm an eye surgeon and she is a gynecologist. So sometimes we are in the operation theater, so we may not be able to take your calls. So please write a message to us and we'll get back to you soon. I have received so many messages in last week that they were not receiving the link for the Google Drive. So we have tried our level best with help of Mr. Piyush from DigiShield to share that link to each and every person. And I have read out the names for those delegates who need to share their Gmails so that we can share the link for the recorded session by Google Drive, via Google Drive. So let's now start today's session, module 2 of the IMA Pune's online certificate course, Diabetes Management, Evidence-Based Diabetes Management. So on this occasion, may I now welcome our faculty for today. Today's first faculty is Dr. Aarti Shahade. I have already introduced her in our last module. She is the main instructor and the convener for this course. She is an associate professor at Bharati Vidyapeeth Medical College and governing council member for diabetic food. She has received many awards, she has published many papers, and she is the main designer of this course so that you will be benefited more and more. Welcome to you, Dr. Aarti madam. And may I now welcome today's chief guest and the chief guest speaker today, Dr. Chittaranjan Yajnik sir. Chittaranjan Yajnik sir doesn't need any introduction as far as when it comes to diabetes. He is professor and director of diabetes unit in KEM Hospital and Research Center, Pune. He is adjunct professor at ISER, Pune, visiting professor in molecular medicine, Exeter, United Kingdom, and a visiting professor at Danish Diabetes Unit. His research interests are mainly high susceptibility of diabetes in Indians, intrauterine programming of diabetes, vitamin B12 and 1C metabolism. He has many awards to his credit. Helmut Mohender Award of International Diabetes, David Becker Medal for International Developmental Origin of Health and Disease Society, Outstanding Investigator Award of the World Indian Diabetic Foundation, 41st Gopalan Oration Award, March of Dimes Higgins Award, and Stanford International Ranking top 0.04% in diabetes. He has many papers to his credit. And on a personal note, I must say, Dr. Yajnik sir, when you were in KEM, I was doing my residency for ophthalmology. In those days, intraocular lens implant had just developed. And we know how in diabetes it was difficult to do IOLs. And Yajnik sir used to guide us how to maintain the doses of insulin for these diabetic patients. And we have given the best possible results to this. May I now request Meenakshi madam to felicitate Dr. Yajnik sir. Over to you, Dr. Meenakshi ma'am. Meenakshi madam, I think she has lost her connection. Welcome, Dr. Yajnik sir. May I request Dr. Arti Shahade madam to welcome you. Dr. Arti madam, please.
Of course, you have already welcomed sir, and you have given introduction befitting him. Sir, I welcome you and eagerly wait for your lecture, and hopefully all the delegates enjoyed it. Thank you very much, sir.
Okay, thank you for the kind introduction. Thank you for the invitation and for choosing this topic of prevention. So let me share my slides and then we can get going. So are you able to see my slides?
Yes, sir. Yes, sir. So just make slide to show. That's it.
Yeah. Okay, some problem making it slideshow. So let me just. I'm going to stop and share again. I just don't know what's the problem. So.
Yes.
Okay, I'm not sure why it's not going in slideshow.
Sir, you need to click on that first button on the top left of the screen, which says from beginning. Just click on that. Yes.
All
Yes.
right, lovely. Thank you very much. Okay, great. Okay, so we are going to discuss today different aspects of prevention and a word which is now getting popular, reversal of diabetes and related disorders. And as you know, I come from KEM Hospital, and I'm always proud of saying that this is the only diabetes unit in the world where the logo is mother and baby. So this has been ever since I started practicing diabetes or gestational diabetes. And subsequently, it was supported by our research with David Parker. Another logo we have acquired over years is this modern Ganesh. And this modern Ganesh, unlike the Ganesh of my childhood, Ganesh in my childhood used to travel on the back of this mouse and roam around. But the modern Ganesh now clicks the mice of the computer and moves very fast. And that's the rapid transition of life course or the lifestyle which has happened. And therefore, our research has concentrated on all these two aspects of intrauterine programming of diabetes and the rapid transition in the postnatal life. And I'll tell you how it actually relates to our prevention and the reversal ideas. So I think all of you know the definitions of diabetes. No need to elaborate this, but we have certain cut points. Okay, if your fasting glucose is 126 or above, we call it diabetes. If your 2-hour value during an oral glucose tolerance test or in random state or after postprandial is above 200, we call it diabetes. If you are measuring HbA1c, a value more than 6.4, that means 6.5 and above is called diabetes. And then there are intermediate values between normal, which is shown in green, and red, which is diabetes, which are called pre-diabetes. and pre-diabetes is borderline diabetes. And the general idea is that when you are young and normal, you are in the green zone. Then as age advances, maybe when you put on weight, or if you have strong family history of diabetes, sometimes due to pregnancy, the sugars start increasing and you move from normal to pre-diabetes and on to diabetes over a period of time. This is the so-called natural history of diabetes. And the reasons for this are supposed to be, one is a susceptibility to diabetes, which usually we ask in our history by family history of diabetes. की तुमच्या आई वडिलांना डायबिटीस आहे का, तुमच्या भाऊ बहिणींना आहे का, काकांना मामाला आहे का, असं. So that is partly genetic, and being genetic we consider it as non-modifiable. In addition, there are precipitating factors which act on the genetic susceptibility and precipitate high glucose values. And these two major ones are age and obesity. So diabetes is considered a disease of aging and disease of obese people. But as we know, in India, we seem to get it at a younger age and at a lower body mass index. And that's why the Western textbook ideas don't apply to us. Age and obesity precipitate diabetes, but these usually also operate through lifestyle factors like inappropriate diet, then physical inactivity, stress, then different aspects of sleep disturbance, and number of other things which come on now as we learn more and more about this. So when people have used these criteria of pre-diabetes in diabetes prevention trials, what they have done is they have included people who are, let us say, in mid-40s and mid-50s. In Western trials, they have all been obese people, so that average BMI was 34. As you know, BMI above 25 is called overweight. BMI of 30 and above is called obese. So they were actually quite obese. We don't see such BMIs very routinely in our practice. And IGT is a pre-diabetic state. So if you were like this, you were included in the diabetes prevention trials. And to me, actually, this is becoming a slight problem because we have artificial cut points for glucose, pre-diabetes and diabetes. So what we are dealing with is a middle-aged to elder individual who is obese and who is already hyperglycemic. And then we are saying that we are going to treat his diet, his physical inactivity. That means we are going to promote exercise, and we are trying to teach him to reduce stress. These were the strategies which were used in diabetes prevention programs. And to me, rather than prevention programs, they became treatment of precipitating factors. You can't treat age, but you can treat body weight and you can treat glucose by lifestyle adjustment. The basic advice was eat less and walk more, which maybe most of us can do in our day-to-day life to try and prevent diabetes. Now, how does this work in the body? And what I have actually drawn here is a figure we have taken from American Diabetes Association publication. And they have drawn this cartoon, which is not actually based on individual data, but this is a conceptual figure which they have drawn from data which was available. So time here means time when you were not diabetic, which means you were normal. And then as we go along the line, we are aging, we are maybe putting weight, and we are moving towards diabetes. And that is shown by gradual rise of this blood sugar. So let us say we start from age 25, then by maybe age of 50, you cross the blood sugar level, which is either fasting more than 125 or PP more than 200, which we call diabetes, but you are rising slowly for many years before that. Then, as you know, diabetes is an interaction between two functions of insulin in the body. So one is that insulin is secreted from the pancreatic beta cells, then it acts on body's tissues. And that action is called insulin sensitivity of the tissue cells. If tissues do not respond to the usual concentrations of insulin in the blood and require higher concentrations, then we say that that individual is insulin resistant. So insulin resistance also increases with age. And what happens to beta cell function is that it keeps or tries to keep pace with the increasing insulin resistance up to a time. But then given your predisposing factors and susceptibility, you start falling off. That may be because you are genetically predisposed to diabetic, or your pancreas hasn't developed properly when you are growing in mother's womb, or there might be a number of other factors which affect pancreatic function. So a combination of insulin resistance in the tissues and failure of pancreas to make enough insulin combine to give rise in the blood sugar, and which beyond a particular level we call diabetes. So that is how actually we see here in the boxes. Initially there are risk factors. Obesity is one of them, inactivity is another. There are a number of other factors. Then comes pre-diabetes, then comes onset of diabetes. And once you get diabetes and high sugars, that high sugar and a number of other chemicals in the blood start acting on the tissues, so you get complications of diabetes. They may be early when they are not symptomatic and they don't affect tissue function, but in late stages, they will affect tissues and cause problems like blindness, kidney failure, foot neuropathy and injuries, etc., etc. Now, this concept of insulin secretion and insulin resistance interacting is the basic concept in evolution of diabetes. And when, like say, I was quite young in 1980s, Professor DiFronzo gave actually a talk at ADA where he called three organs as important in diabetes called triumvirate. And that triumvirate of diabetes was pancreas, which is here, insulin secretion decreased, then liver and muscle. Liver that time was thought to be the main contributor to insulin resistance, equally muscle. So triumvirate means interaction between these three organs was considered responsible for generation of diabetic state. Over years, now we have understood that many more organs are also involved, either primarily or secondarily. Primarily means their function contributes to deranged glucose metabolism when they stop functioning normally. And secondarily means they get involved, change their function when the sugar starts rising, and then secondarily contribute to deterioration of glucose intolerance. And various organs which are now involved here are, like say again, gastrointestinal tract, and the current interest in gastrointestinal tract is the GLP-1 secretion, which is a stimulator of insulin secretion on one hand, and also has effects on brain and other tissues. Then kidney, which is supposed to reabsorb glucose, which is excreted in the urine, and as glucose starts rising, kidneys then actually change their threshold for glucose excretion. That means they reabsorb more and more glucose without excreting it in the urine. And this in turn increases blood sugar. Similarly, fat tissue that has a number of abnormal actions. It secretes a number of hormones. It secretes a number of chemicals called adipocytokines, and they affect different organs and raise the blood sugar. And importantly, brain again has a number of effects on different organs which affect the insulin secretion or insulin resistance or reset various functions in different organs so that body moves towards diabetic state. And therefore, when Professor DiFronzo gave a second talk almost 15-20 years later, he called it, instead of triumvirate, that means 3 organs, he called it ominous octet, 8 organs. So we now know multiple organs can be involved in generation of diabetic state. And by the time Professor DiFronzo gave talk, he hadn't thought of one more organ in the body which might also contribute to diabetic state. And that is the new idea, microbiome. And I think many of you are aware that in our body, we have billions of bacteria in different places, in gastrointestinal tract, in other body cavities, then over the skin, in the nose, in the mouth, everywhere. And these bacteria have extremely good relationship with the body cells so that they promote health. But when their composition of microbiome changes, they might have a number of different bad effects on the cells. And that can contribute to diabetic state. In fact, from KEM Hospital, my unit was the first to publish disturbances of microbiome in Indian type 2 diabetic patients 5-7 years ago. In addition to these different organs interacting with them or functioning and dysfunctioning amongst themselves, there is a new concept which is called a life course perspective on diabetes. And that's also called developmental origins of diabetes. And this has been actually our contribution to research for last 30 years in KEM, ever since I met Dr. David Barker and started working with him. And what it says here is that in addition to genetic factors, which we have seen comes from our parents, there are many additional epigenetic changes which happen either in the sperms or more prominently in the ova, and then in the developing fetus in the mother's womb, depending on the environment of the uterus. And this is called epigenetic programming of diabetes, blood pressure, heart disease, etc. What it means is that the gene function is altered by the environment of the uterus, which may be either undernutrition of certain nutrients or overnutrition by way of maternal diabetes. And that changes the developmental structure of the fetus in such a way that its susceptibility to diabetes in later life is considerably increased. And these epigenetic changes continue to happen in the body cells as we grow from, like say, either first in the mother's womb and then outside as a child, then as an adolescent, as a young adult. And this is a whole life course, like say, approach to developmental origins of diabetes and other things. I'm going to tell you a little bit about this later on. This is a relatively new concept. And for that, we actually set up a study with Professor David Barker in 6 villages near Vadu, where KEM has a primary health center. And what we did was we studied over 2,500 non-pregnant women in the villages. They were married but not pregnant, so likely to become pregnant during 3 years of our follow-up. More than 800 of them became pregnant. We studied them quite intensively. We then measured their babies. We continued to measure the babies every 6 months after their birth for their growth and development. And every 6 years, we invited the two parents and the child born in our study for very detailed studies of their metabolism, their heart function, their nutrition, their body size and composition, their neurocognitive function, and recorded all this information. In 2019, we had started our 24-year follow-up, but COVID stopped it. Thankfully, a month ago, we have now started again. So we had a gap of 2 years. This is one of the best follow-up study in the world, starting with mother from when she was not even pregnant, then during her pregnancy, and then the baby is born and the parents serially, and this is going on for last 30 years. And I'm going to just tell you that when these children born in the study were 18 years, they were actually quite thin. Their BMI was 19. So 18.5 and below is called undernutrition. They were just 19 BMI. My BMI is 22, 23. So still people call me thin. So 19 are the village thin young people, but 28% of them had pre-diabetes. It came largely from higher fasting sugar, especially in boys, but also 2-hour glucose, which was high in both boys and girls, about 10%. And occasional girls were diabetic, frankly. The prevalence or occurrence of this pre-diabetes was twice as common in boys compared to the girls. So let us say 37%, 18%, or roughly you can say 40% and 20%. So that's a very high prevalence of pre-diabetes at a young age in relatively thin rural people. And then because, as I told you, we had studied them every 6 years for their glucose tolerance test, we were able to plot their glucose. And what have I done here is that those who had pre-diabetes at 18 years are shown in red, and those who were normal glucose tolerant at 18 years are shown in blue. And what you can see is that those who were pre-diabetic at 18 years had higher glucose throughout their life from 6 years, 12 years, and 18 years. And if we look at their insulin resistance and secretion, etc., there was a very systematic change over years in them. So that, as I told you, we all become more insulin resistant. That means less sensitive with increasing age. Yes, but those who became pre-diabetic had a more fall in insulin sensitivity. And when we considered their pancreatic function, beta cell function in relation to prevailing insulin resistance, we could see that their beta cells were not functioning properly right from 6 years of age, also at 12 and 18 years of age. In other words, those who had pre-diabetes at 18 years had higher glucose throughout their life, and they had a lower beta cell function in pancreas throughout their life. That means that what we diagnose at later age was actually being present, though at a lower or a less milder form. And then we had a lot of data, so we tried to do a multivariate analysis to see how did people with pre-diabetes differ from those who did not have pre-diabetes. And what we found was those with pre-diabetes were born with a shorter birth length, and they had a smaller head circumference at birth. and their mothers were not overweight or obese. On the other hand, higher maternal glucose, even though it was in normal range, was also associated with prediabetes in the child. And father's high glucose was associated with higher glucose in the daughter. In other words, it's a mixture of factors. The baby hadn't grown very well in utero, but at the same time, there was more glucose in the mother and father, even though they did not fit the description of diabetes. This is, like say, possible to know only when you have serial data. And my department is one of the few in the world where such data is available. But what actually we are now trying to say is that undernutrition of the baby for linear growth, but overnutrition by way of maternal glucose was driving, somehow or other influencing risk of prediabetes at later age. And when we looked at their 6-year and 12-year glucose, what we found was if they had higher glucose at 6 years, their chances of becoming pre-diabetic progressively increased. That means the lowest fifth of glucose, if they had 20% chance of becoming pre-diabetic, the highest glucose people had 45% chance of being pre-diabetic. Similarly for 12-year glucose. In other words, glucose concentrations, if they are higher at 6 and 12 years, your chances of getting pre-diabetes at young age are higher. Again, simply said, you run higher glucose throughout your life. And are we the only ones to say this? Of course, we have such a linear data, but a cross-sectional data in different states in India, in young children between 5 and 9 years, and adolescent children between 10 and 19 years, which was published in 2017. It's called Comprehensive National Nutrition Survey. It showed that prediabetes was common in children at as young as below 10 years and also in pubertal children in different states. So the color of the state is proportional to the number of children who have prediabetes. Darker the color, more number of children had prediabetes. And you can see this belt, and many states in India have a prevalence of prediabetes in young children, which is more than 10%, these two dark lines. And at, again, 10 to 19 years, prevalence more than 10%, increasing in different states. So this is quite surprising to many because we don't think like this. And it is also a wake-up call for the policymakers, for the doctors, for the parents, that we should perhaps measure glucose in children to see whether they have a glucose abnormality at young age, so that we can inculcate good habits in them for diet, exercise, stress management, etc., so that we try and reduce their progression into diabetes. This is another graph which charted rise of occurrence of diabetes in different states of India between 1990 and 2016. This is called GBD India study, Global Burden of Diabetes. And Global Burden of Disease, I am one of the authors on this because we contributed to these ideas. And what you can again see is that the red states and the pink states are again across the similar belt, like what we saw in the last figure. That means certain states are at a higher risk, and maximum rise of diabetes in these 25 years happened in states which are not really very affluent: Odisha, Chhattisgarh, Uttar Pradesh, Uttaranchal, Uttarakhand, then Jammu and Kashmir, and the northeastern states of Assam and Nagaland. These are traditionally deprived states. And it's quite surprising that they are facing the largest rise of diabetes. And one of the answers for this I learned was from David Barker. That is his picture. He is no more now. He passed away in 2013. I was very close to him. He was like my daddy. And in 1991, he came to see me to show this slide actually, where he had found that in a study in England, where he had birth weight of these people from the hospital records, he was able to find out the association between birth weight, which is plotted here, and being diabetic or having syndrome X, what we now call metabolic syndrome, at age of 65 years. And what you see is lower the birth weight, higher is the risk of IGT and diabetes at 65 years age. Lower the birth weight, higher the risk of metabolic syndrome. And he called this a thrifty phenotype hypothesis because he was trying to say that lower the birth weight, higher is the risk of diabetes. And he said type 2 diabetes is the outcome of the fetus and early infant having to be nutritionally thrifty. That means it wasn't getting enough nutrition, so it had made changes during its development to different tissues. So maybe pancreas hadn't developed well, and therefore they face diabetes in later life. Same thing can happen to different organs like liver, kidneys, brain, heart, etc., and produce a range of different diseases like blood pressure, heart disease, dementia, non-alcoholic liver disease, etc., etc. So this was the idea. He said that undernutrition in the uterus can increase the risk of diabetes. And you know, Indian babies are the smallest in the world, and therefore he thought more research needs to be done in India, and that's how he ended up seeing me. At the same time, people had also found out that if mother had diabetes in pregnancy, what mostly we call gestational diabetes, but it can be type 1 and type 2 diabetes which were present from before pregnancy. In this case, there is increased supply of maternal fuels to the baby. That also taxes the fetal islet function. On one hand, it produces an obese baby, what we call macrosomic baby, that becomes an obese child and gets high sugars right from early age, like childhood or puberty. And that in turn manifests later on in girls as gestational diabetes or a post-gestational diabetes. In other words, both undernutrition as well as overnutrition of the fetus while growing in the mother's womb can lead to increased risk of diabetes. And therefore, we have to think of prevention in a broader sense. We can't go to 45 and 55-year-old adults and say we are going to prevent diabetes. Yes, I mean, in older people, you want to do it. But as a society, we want to think of earlier stages. And that's why I have drawn this figure. We usually think of primary prevention. That means before diabetes has occurred, that means mostly people have tried it in pre-diabetes state. We are now talking of primordial prevention. That means even very early in life, when risk factors are also not developed. So you are even trying to prevent the risk factors. And this is usually intergenerational. That means either mother's health, which is undernourishment or overnourishment. Their children are at higher risk, and therefore you can try and prevent it quite early in the age. So this becomes a population approach. In primary prevention, we usually do high risk approach. People who are older, obese, have IGT, that's where we try to do primary prevention. Secondary prevention is to prevent complications in diabetes. And tertiary prevention is to prevent end-stage disease complications in diabetes. In other words, we are trying to either prevent diabetes or prevent risk factors, or to prevent complications or prevent premature death and bad outcomes in diabetes. And it's possible as doctors to help people at all these stages. In your practice, you might have a diabetic patient of 20 years duration. There you can do secondary and tertiary prevention. For their children, if they have IGT or obesity, you can say, let's do primary prevention. And for their children, you can try to do primordial prevention. So as a doctor, you can help the patients, their families, their children, their grandchildren in various ways by increasing the awareness in them. Screening for relevant tests and simplest test will be blood glucose, and various nutritional and other programs which will help them improve their lifestyle. Then as we go along the line, then it ultimately becomes drug treatment for various things in addition to lifestyle. And that is how I would like you to remember your contribution to prevention in diabetes. Right from very early stage, then in young people, and then finally in patients and as they become old. And this is how I told you in diabetes prevention trials in the Western world, these were the people 45 to 50 years, BMI was high and they had IGT. And the trials, first two trials were actually done in Finland and USA and China, three countries. And in each of these countries, what they showed was if you improve their lifestyle, that means you eat less, you walk more, you exercise and you lose weight because obesity is their major driver, then you can have a substantial reduction in progression to diabetes. So it was about 60% reduction in American trial, 40% reduction in Finnish trial, 50% reduction in Chinese trial. India also had its diabetes prevention program done by Dr. Ramchandran in Chennai, who is a very famous diabetologist, a great researcher. He did Indian diabetes prevention trial. And what they found was compared to the American trial, where the fall in the progress to diabetes was quite substantial. That's like, say, something like 60%. In Indians, the fall which he achieved over a period of 2 to 3 years was about half of that, let's say 25 to 30%. And for Indians, lifestyle achieved same as addition of a drug called metformin, which is what you use in treatment of diabetes. So addition of metformin to the treatment did not improve the success rate. Now, this may be because A, our patients were younger, and B, like say, we were not able to do that much intensive intervention as they were able to do in American trial. American trial was a multi-billion-dollar trial. Dr. Ramchandran's trial was only few lakhs of rupees. So that may be one reason, but there might be differences in biology. So what I'm telling you is intervention trials have happened all across the world in pre-diabetic people. In Western people, they have been able to reduce the risk of diabetes prevention by almost 60%, in India by about 25 to 30%. Then a number of other drugs have been used for prevention like acarbose, pioglitazone, rosiglitazone, orlistat, then anti-obesity drug, phentermine, topiramate, and bariatric surgery. And as you can see, there are some impressive results, like say for these drugs which reduce weight, either bariatric surgery or anti-obesity agent, but this drug had number of other side effects. And pioglitazone. All these three actually reduce the risk by more than 70%. And it's important to remember that this can be done. And that effect lasted for more than 10 years in the American trials. So what happened was the lifestyle people continued to have lower incidence of diabetes even 10 years after starting the trial compared to the placebo and compared to the metformin. So lifestyle was quite effective for 10 years afterwards, though, as you can see, the graph is going up. That means more and more people are becoming diabetic, but within these three groups, less number are becoming diabetic in the lifestyle intervention. Then came actually quite a shocking paper. And this was published only last year. And this was a follow-up of the diabetes prevention trial in the US. And what they did was they looked at mortality in the diabetes prevention program 20 years after start of the trial. And what they concluded was cancer was the leading cause of mortality among adults at high risk of type 2 diabetes. And although metformin and lifestyle modification prevented diabetes, neither strategy reduced all-cause cancer or cardiovascular mortality rates. That means that though the diabetes prevention trial was able to reduce the risk of diabetes, it was not able to reduce the risk of cancer and mortality from either cancer or cardiovascular causes. This is an eye-opener that if you start at late age and with obesity, etc., the benefits may be only partial. In my department, one of my PhD students, Tejas Limaye, did a trial in the IT industry in Pune. And what we call that trial as LIMIT, lifestyle modification in IT. And what she did 10 years ago. What she did was virtual assistance-based lifestyle intervention in high-risk IT employees. So we are gone to 5 IT industries and measured cardiovascular risk factors. And to our horror, at an average age of 38 years, 65% of the employees had 3 or more cardiovascular risk factors. So they were in need of advice to reduce their risk of cardiovascular events, diabetes, etc. And being IT employees, we thought if we give a virtual advice to them, that means using social media, let us see whether we can influence their body weight, which is a major problem, and other risk factors. So what she did was she sent 3 mobile phone messages and 2 emails every week. She had created a total of 150 messages and 100 emails. So no message was repeated in 1 year. Then emails were containing infographics, so picture and text. She sent it at a particular time of the day in consultation with these people. Okay, which time would they like to receive it? And there was additional support to a website which actually provided all the information of how to do diet, how to do exercise, how to do stress management, etc. And what we found was that in the intervention group, the prevalence of overweight obesity decreased quite rapidly in first 6 years by almost 10%, and then flattened out between 5 to 6%. While in those who were in the control arm, that means they did not receive the messages, there the overweight obesity had increased by 7% after 1 year. So after 1 year, the difference between these two groups was actually 7 and 6. That means 13% difference. Here it was increasing, here it was lower. So it was interesting that simply sending messages and making them do things will actually help them. And we found out that if they achieved more and more intervention goals like weight, glucose, cholesterol, blood pressure, triglycerides, etc., then the effect was better and better. So in other words, if they were more intensive in their approach to their lifestyle, there was a bigger benefit. So thus, what we are now seeing is in the natural history of diabetes, we can see prevention trials happening in pre-diabetes. We said primordial trials can be done here. I am not going to speak much about that, though we have started a trial like that. And there is a new word now for people who are diabetic. If we do intensive efforts of what you do in prevention trials, there might be remission of diabetes. Remission means either a partial or complete disappearance, either for short time, for a long time. That means that person then is able to maintain glucoses without any treatment. So remission, I call it taming of diabetes. So we look at glucose and HbA1c levels, we look at medication effects, and we see how long it lasts. And therefore, in clinic, we usually talk of diabetes control. If we are able to achieve normal glucose and normal HbA1c without any medication for a reasonable length of time, like say 1 year or more, then we call it remission. If it lasts for 5 years, we might even call it cure. And in clinic, what we are usually achieving is control. That means controlling HbA1c within normal limits, glucose within normal limits as far as possible with medication. So these are progressive, like say, more intensive programs: control, remission, and cure. And for this, there are various ways of doing it: nutrition, activity. Weight loss seems to be a very important issue. People can use drugs. Surgery is bariatric surgery. There might be other ways of doing it. Alternative forms of treatment, yoga, whatnot. And I'm going to tell you about only one study which was done in Scotland in primary healthcare. It's called Direct Trial, where they put their diabetic patients on severe restricted diet, that is 800 calories for 3 months to make them lose weight. And after these 3 months, they gradually reintroduced normal diet, but they were always eating less than what they should be eating. And many of them lost 10 kg or more weight within 3 months with that restricted diet. And if you lost more and more weight, then the number of people who were remitted, that means proportion of remission at 12 months, was 86% if that person had lost more than 15 weight. They started with an average weight of 100 kg. So 15% weight loss, 86% remission. 10 to 15%, let's say 50%. 5 to 10 kg percent reduction, 1/3. So quite impressive this thing. They have published their 2-year follow-up now, where the average remission from a total of 60% for the whole group has come down to about 40–45%. But still, half of people at the end of 2 years are without any medication and with normal glucose and HbA1c. So intensive efforts in diabetic patients to restrict diet and lose weight can be successful. How long it lasts, we don't know. How long when you can maintain such diet and weight, that also we don't know. Many people relapse, but we have proof of principle that it may be done. And therefore, and I am now coming to a bit of primordial trials. And primordial trials actually can be done in women of reproductive age, either before or during pregnancy. And as I told you, both low birth weight and large birth weight in diabetic pregnancies, these babies are at higher risk of diabetes in future. And therefore, if we improve health of the mother before conception and in pregnancy, to improve her nutrition, to prevent or control her diabetes, we might succeed in reducing the risk in their children. And this slide I always like to show. In the previous slide, I have said pregnancy is an experience for the two, for the mother and the baby. So let's say this was a male child. If it was a female child, then very interestingly, I don't know whether you know this, by 20 weeks of gestation, the ovary of the female child in the mother's womb has all the 1 million ova which she is always going to have in her life. In other words, if a woman is pregnant with a female child, from 20 weeks onwards, we are actually dealing with 3 in 1. So there is this pregnant mother herself, the fetus inside, and the next generation which is present as ova. And you can see this is a very powerful model for intervention in a community whereby we can improve the health and reduce the risk of disease even in the 3rd generation. And I think actually I will reduce this, actually we will discuss more. We have followed up children born to diabetic mothers at an average age of 15 years. And in the first study, we studied 200 children. And what we found was children born in diabetic pregnancies had higher risk of diabetes and pre-diabetes at 15 years of age. So almost 40% of them had either pre-diabetes or 5% had diabetes. While in children born in non-diabetic pregnancies, there were only 20% pre-diabetes. And in children below 10 years, where we did not do the glucose tolerance test, just did a capillary glucose, we could see still there was a difference in glucose. Young children born in diabetic pregnancies had higher glucose. So these are powerful statistics which should actually wake us up to take action in children who are born either low birth weight, that means they were grown poorly in the uterus, or children whose mothers were diagnosed with diabetes, either gestational diabetes or they had diabetes from before pregnancy. And these statistics could be improved if we act within pregnancy or after pregnancy to improve the lifestyle of these children. I'm going to now stop, but I'm going to advertise for a film which we have made. Dr. Sumitra Bhave did this film for me and Dr. Mohan Agashe. So 3 of us got together and we made this film called Sakre Peksha Gold. It's a beautifully done film on the KEM Hospital Diabetes Unit, research in pregnancy. And what it tells you is how to improve mother's diet in pregnancy to reduce the risk of diabetes and other disorders in the baby. I invite you to visit YouTube, go to KEM Hospital Pune site, and this is the link. It's a 25-minute film. Okay. And on that Bhadipa, we had 1.2 million hits for this film. So I would suggest you all look at it. You can even play it in your outpatients, especially if you are a gynecologist obstetrician, but also for all other specialties, for general practitioners and family physicians. If you show this film in your outpatients, many people will learn how we can improve the health of our next generation by improving the health of the reproductive age women. So I'm going to stop here. Very happy to take questions, comments, but I would like you to think and think how you can contribute to prevention of diabetes and related disorders in your practice. And as I said, you can treat patients That will be secondary and tertiary prevention. That you need to do very meticulously. You can go to their children and try primary prevention. You can think of their grandchildren and think of primordial prevention. And that way we will be able to control this terrible epidemic of diabetes and other conditions. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir. I request Dr. Aarti Shade, madam.
Thank you very much, sir. Of course, it was the lecture which I think I wanted to listen to, and maybe listen to it again all over. That will be the next certificate course, sir.
Yeah.
And sir's tagline is prevention. And as I think there are more than 100 participants in this group now. I hope everybody picks up at least one small point from that lecture. That is how to prevent, at least in your neighborhood, in your family, the diabetes. I think we should be able to get at least a few small numbers less in next decade or so. Thank you very much, sir. I'll just check for the questions if there are any on the chat box, and I'll get back to you, sir.
Can we ask one question till then, Aarti Shade, madam?
Yes, please go ahead.
Dr. Chittaranjan Yadnik, sir, that was one of your best presentations, I think, over the past. It was very nice. Only thing I wanted to ask is, suppose a baby, a anomalous baby is there and the ovaries are normal. Can the mother, in some cases, we do like ovarian preservation. So does this hamper the oocyte? For artificial reproduction techniques, what we do is we take out the ovum and we preserve them.
Yeah.
Then we give it to the next time for the embryo preparation. So
Okay.
in these conditions, is there any environmental factors which can affect the oocyte so as to create some diabetic or endocrinal problems in the next fetus?
Excellent question. So one thing is that ovum has been in that woman's ovary from 15-20 weeks of gestation when she was in the mother's womb. So that ovum has been exposed to a whole lot of environmental challenges which that mother might have faced. So that's one aspect. When we are doing artificial sort of reproduction, in IVF or whatever, you of course grow these ova and the fertile ovum into a in vitro situation. And though the composition has been worked out so that the embryo survives, still there are many perceived problems during the development. Recently, I saw a paper where they studied a range of cardiovascular outcomes in children born in IVF pregnancies against those born in normal pregnancy. Now, such studies are to be interpreted with some caution because the women who go for IVF are not normal. They may be older, they may have disease, there is more chance of diabetes, obesity, etc. So all these risk factors play on these ovums. But that paper highlighted that up to 30% of children born in IVF had some form of abnormality. They may not be major at all, but some form of abnormality which would predispose them to problem later in the life. So therefore, this is called epigenetic change.
I know.
So these are the changes introduced in the chemical modification of DNA molecules. So the genes themselves are like that, but there are layers of additional chemicals which are added, and they change gene expression either during development or subsequently and lead to a number of manifestations. So your question is very important, and IVF is known to be a risk factor for increased developmental abnormalities, and now we know for cardiovascular disease outcomes.
So there's one question in the chat box. Is sudden weight loss advisable as done in direct study?
Yeah, so in direct study, they were on average 100 kg. So they were obese, their body mass index was 34. So for them, this was one way of achieving a weight reduction. Whether acute weight loss does any damage, at least in that trial, it didn't happen. In that trial, there were hardly any adverse effects of that weight loss because they were monitored closely by the nurses and the field staff, and there were benefits. Whether this will work in our 60 kg patients, I have no idea. And therefore, I am in the process of setting up a trial, which I am calling indirect. It's Indian direct trial, indirect.
Okay.
We are just now submitting for ethics permission. And the first phase of our program will look at feasibility and safety of doing such an intervention. And I may be able to tell you by next year whether we see any such problems. In the meanwhile, I would probably go a bit slow. I wouldn't consider 15 kg weight loss in 3 months. But if we think of 7 to 8% of the body weight, then at 60 kg or 70 kg, that will become 5 to 7 kg. That could actually be tolerable.
Sir, there's one more. Is there any data where we have both the parents undergoing prevention trials by lifestyle modification?
Very good question. So there is now increasing interest in contribution of male epigenetics to fetal programming, because up till now we have studied mostly mothers. Now there is an increasing interest in studying epigenetic changes in sperms, and the study which is happening at Harvard, I know the investigator very closely. She is a passionate person about male epigenetics, and what she is doing is she is trying to make young diabetic fathers control their diabetes very strictly for many months before conceiving their wives. And therefore, in addition to maternal inputs, she is now thinking improvement of diabetes in the father to see whether that would epigenetically modify the sperms for better health of the baby. These experiments are not easy to do. She's doing it, and maybe in a year or two, we will have some results. But point well taken, that both parents can improve their health to improve the health of the next generation. So we need not only concentrate on mothers, we can also concentrate on fathers.
Thank you very much, sir, for the wonderful topic, wonderful lecture. And of course, as usual, you are very, very inspiring. So I always should get up and think, what do I do next? And how do I meet all those goals that you have set for us?
You had Dr. Arvind. Hello. Hi, Arvind.
Yes. So next is Dr. Arvind.
I was
actually
listening to your lecture, like a small student. I was in DRC in 1988-89 when Dr. Yajnik would come as a researcher. So since then, I've been like a student to him and then literally listening to all his lectures. No, I just had one question. I actually sent it to Dr. Mohan and others. I wish I had sent this article to Dr. Yajnik. This came out on 22nd March, actually. Preconception, anti-diabetic drugs in men and birth defects in offspring. And very shockingly and surprisingly, this article talks about preconception paternal metformin treatment is associated with major birth defects, particularly genital birth defect in boys. I mean, I sent it to all the past presidents of RSSCI in that group because this is the first time I've heard that use of metformin can actually lead to some birth defects. I mean, I don't know whether I have to take it with a pinch of salt or probably a vessel full of salt. And I mean, this is the original research. I mean, I would definitely send it to Dr. Yajnik later today. I think it's probably worth proving or disproving this.
Yeah, Arvind, I've seen that paper.
Yeah.
And I'm just going to study it a bit more to try and dissect out how maternal health might also happen. But they had actually done very nice design. कि mothers were not diabetic and they were healthy. And despite that, paternal drug treatment of diabetes was associated with increased risk of a urogenital sort of developmental defects. It's a beautiful study. Just now, I was trying to remember it to include it in the answer, but you actually reminded me. So thank you very much. And that again says that preconceptional interventions, especially now drug intervention, and also we think of various environmental pollutants, which are broadly classified as EDCs, endocrine disruptors, endocrine disruption chemicals. They are supposed to have many effects on the developing fetus. And then the story gets more and more frightening, because we are just bathing in them in the atmosphere. And there might be very small changes in the fetus which may not be detected by routine tests, but major ones can obviously be detected, and that's what these people found out. So yes, thank you for reminding that. And that again sort of asserts that both parental contribution to development of the fetus can make a difference to the health and disease susceptibility. And that is the science of what actually I belong to, which is DOHAD, Developmental Origins of Health and Disease. Thank you, Arvind.
Thank you, sir. Thank you so very much.
Dr. Yajnik. May I now request the President of IMA Pune, Dr. Meenakshi Deshpande, to felicitate Dr. Yajnik, sir. Sir, this is slightly virtual.
So this is your virtual felicitation.
Thank you.
Accept this.
Thank you very much.
And a moment.
And this is Uparana, sir.
Yes.
For you.
This is Uparana.
I'm going to put it. Yes.
Yes, yes.
Thank
sir.
you.
It's like this.
So
Thanks.
please keep yourself available on 19th of June. When
Okay.
we will be felicitating you physically in our hybrid conference.
Thank you very much. I'll be there.
Yes, sir.
Yes, sir. Thank you, sir. May I now welcome Dr. Arvind, sir.
I'm already here.
Yeah, just a moment, sir. Welcome, Dr. Arvind, sir. He is Director, Diakon Hospital, Bangalore, Chief Consultant at Diakon Hospital and IDF Center, Consultant Diabetologist, India, Asia.
Move that slide, please. Sir, slide is not visible.
This slide is not visible?
No. Go down. Scroll down.
Just a moment.
No.
Can you see now?
Yes, right. Done.
Okay.
He's a consultant, chief consultant at Diakon Hospital IDF Center of Excellence, consultant diabetologist at Columbia Asia Fortis Hospital. He's the course director for PG studies at RGUHS and RSSDI, JNU University. He was president RSSDI 2015-16, president Diabetes India, has conducted over 100 phase studies, has over 100 publications, and has authored many textbook chapters. So welcome, Dr. Arvind, sir, and we are eager to listen to your talk.
Thank you so very much. I'm honored by this invitation by IMA, and then thank all of you for having given me this opportunity to be here. And it was wonderful listening to Dr. Yajnik speak just before I came in, because I've always looked up to him for inspiration at all times. So I will be sharing my screen. Request somebody to tell me whether the screen is visible.
Yes, your screen is visible.
Yes, make it. Yes, good.
Thank you so very much. So I think the topic is very clear here. The topic is, should sulfonylureas be retired? I thought I will start with this first slide, which basically gives us insulin sensitizers on one side. Because if you're talking about type 2 diabetes, we have to remember it is both insulin resistance and insulin deficiency. While the insulin resistant continues to be the same during the entire course of the disease, the insulin deficiency over the years will continue. And normally it's a known fact that maybe by the end of 5, 7, or 8 years, the oral hypoglycemic agents alone may not be sufficient. So majority of our patients will be requiring insulin. So what are the insulin secretagogues that we have? On one side, if you look at this, it's very clear that you actually have sulfonylureas. That is what we have been using. And of course, we will be using DPP4. So I will not go into the details of an injectable at this point of time. Well, I will also not talk about the insulin sensitizers or the other nutrient load reducers that we have in the management, because the topic is, should we have to retire sulfonylureas? Now, what should be the quality of an ideal oral anti-diabetic drug? Now, this is the question that we always ask. Well, the first thing is, it must have a robust evidence base. It should be well validated over a period of time. It must have a good potent glycemic action. It should be durable. It should have the weight benefits, or it should be neutral with respect to weight, or hypoglycemia should be low or no hypoglycemia. It should be cardio safe, and most importantly, cost effective in a country like India. Now, with that background, let's see where we are with the sulfonylureas before we talk about retiring sulfonylureas. So I will start with the potent glycemic action and the durability. Now, if you just look at this particular slide, which compares sulfonylureas with other anti-diabetic drugs, it's very clear the expected decrease in HbA1c with monotherapy is as high as 1 to 2%, depending on the starting HbA1c of this particular patient, especially when it is added to metformin. So the sulfonylureas reduce HbA1c to the maximum level among all the add-on agents, and this is extremely clear. Now, if you are comparing it with DPP4, I think HbA1c reduction is far superior with sulfonylureas compared to DPP4s. So HbA1c, as we know, is the gold standard, which tells us the efficacy of a particular drug. So the HbA1c reduction with sulfonylureas are the best among OADs, and next only to insulin. Now, this is a point that we should remember, next only to insulin. Now, why do you want to retire your best? I think that is the question. Okay, now as we take forward, we will answer, do we really have to retire such a great drug? Let's look into the weight, because one of the allegations is sulfonylureas gives you weight. Weight is not a good thing in a person with diabetes. Therefore, you should use a DPP4, which probably is weight neutral. Now, let's look at this. And this is from the Carolina trial itself, where glimepiride was actually compared with a sulfonylurea and with the DPP4 linagliptin. So the weight increase compared to glimepiride linagliptin weight increase was just about 1.5 kgs. So only a marginal increase in the weight was seen. Initially, it was about 0.6 kgs. And by the end of 5 years, it was about a kg or a kg and a half. You know, this is not a great deal at all, because if this is what we are worried about, we can always alter the diet to suit, because when we start insulin, we know the weight gain is going to be there. And this is from the advanced trial where glycoside was used. In fact, the weight gain was actually 0 in the advanced trial. So that settles the issue of the weight. Yes, some trials have reported an increase of maybe 1 to 2 kgs over 5 years, but this can easily be counteracted by a small increase or decrease in the diet. So that should not be the point of contention to say, I'm going to retire your drug. Definitely not the way. Now let's look at hypoglycemia, because we know hypo can be a problem with sulfonylureas. But the question is, in the medical marketing, there has been a very unfair comparison when they want to sell their drugs. But when insulin is used, all of us should remember, nobody talks about hypoglycemia at all, because we know at some point of time, we have to use insulin in all our patients. And when insulin is used, hypoglycemia is a part and parcel of it. So there is no way you can actually develop an insulin which does not give hypoglycemia. So hypo with sulfonylurea is not a side effect, but it is the effect of good efficacy. I don't think we should blame sulfonylurea. Now, how to actually manage this, I will come to that a little later. But in any person with type 2 diabetes, whether he is on insulin or oral agents, you can see that hypoglycemia is going to be a problem. Our education must strengthen to teach all our patients about what hypoglycemia is. Sulfonylureas are very powerful insulin secretogogues. Giving too much is a problem, so we need to be cautious and careful in dosing. The way we initiate and intensify insulin, the sulfonylureas can be started on a low dose, and then it can be intensified. There is no need to start glimepiride at 2 mg twice a day or 3 mg twice a day. You can start with 1 mg, watch the blood glucose over a period of time, teach your patients, and then step up the dosage. So hypo to me is too much of the effect and not a side effects. And patients need education about this. It's not a major problem. It just needs a little bit more effort by all the physicians and educators. And this is about, especially hypoglycemia in one of the other trials, but we can actually skip this. There is enough number of papers to tell you that when you compare sulfonylurea with a DPP-4, the increase in hypoglycemia is a very, very small percentage. And in this case, glimepiride versus a DPP-4 was actually 9.1 to 11.2, a very small absolute difference. So whether you're starting insulin or sulfonylurea, hypoglycemia can be a problem. I think with good education, starting it in small dosage, stepping up, will actually take care of this problem. All right. Now, this is from the Carolina trial itself. Okay. Now, what I would like to highlight is, yes, it reported 3 times higher hypoglycemia on the glimepiride group, but importantly, despite the increased hypo, there was no increase actually seen in terms of death or hospitalization due to hypoglycemia or heart failure. Now, this is very surprising. The hospitalization due to heart failure was higher in the linagliptin group compared to the glimepiride group, even though hypoglycemia was 3 times higher in the Carolina trial. And there has been no explanation for that, because generally it is told hypo can increase the death. Now, that did not happen in the Carolina trial, which clearly told us that hypo was not a problem in most of the patients. And I'll also tell you why this kind of a hypo happens in a trial like Carolina. Patients on glimepiride were actually uptitrated from 1 to 2 mg and then from 3 to 4 mg and from 3 to 4 every 4 weeks. So that within 16 weeks, most of them, that is 61% of them, on 4 mg glimepiride, considered to be equivalent to 5 mg dose of linagliptin. I mean, nobody really knows how 4 mg was equated with 5 mg dose of linagliptin, because 4 mg is a submaximal dose, but we will talk about it later. So when patients are basically titrated like this, hypoglycemia can be a problem. So in clinical practice, what we do is We start with the low dose, see what the blood sugar response is, because each patient can be different. And if necessary, we titrate the dosage. And in the Carolina trial, especially in groups where the HbA1c was 7.2, the use of sulfonylurea in this kind of patient population, we know can increase the risk of hypoglycemia. Now I'll show you this slide from the advanced trial where glycoside was used. In fact, the severe hypoglycemia was very, very less. It was seen only in about 0.7% of the patients. Okay, now to end this argument about hypoglycemia and sulfonylurea, yes, hypoglycemia is there. We do see it in the modern sulfonylurea, which is glimepiride and glycoside. So you must be cautious. You must tell your patients, just the way when we start insulin, we teach them. And start with a small dosage and step it up. And again, hypo should not be the reason to actually retire this drug. Now we'll come to cardiac safety. There were no trials of CVOT with any of the sulfonylureas. In fact, there were a number of trials with the DPP4s. But when linagliptin had to go through a CVOT, which is called the Carolina trial, FDA decided instead of a placebo, they are going to pit linagliptin against glimepiride. And this was a very bold step. People thought when this trial was started, is it the end of glimepiride? Will linagliptin score over glimepiride? Do we have to stop glimepiride in future? But surprisingly, if you look at this, this was a great trial. I will not go into the details. It had the longest follow-up. It had two arms. One arm was linagliptin 5 mg plus the standard of care. Another arm, glimepiride, started with 1 mg, titrated to 4 mg over 16 weeks along with the standard of care. Now, if you look at the 3-point maze, the curves are actually hugging each other. There is absolutely no difference between linagliptin and glimepiride. And this is the 4-point maze. Again, no difference between linagliptin and glimepiride. So the cardiac safety is as good as that of linagliptin. It is not inferior to that at all. Only thing that came out was, yes, hypoglycemia value less than 70 was about 3 times higher, especially in the first year, but not later on. And we already discussed about this particular point. Even though this was highlighted that glimepiride can cause more hypoglycemia, hospitalization due to heart failure was actually much less. Let's see what some of the great people in the field of diabetes said, and this is coming from Rosenstock. He said, with this study, we provide very specific data for the magnitude of risk of hypoglycemia and of weight changes, so people can decide whether to use it or not. And the difference between a $10 pill and a $150 pill. So the DPP4 inhibitors make billions of dollars, so there's going to be cost considerations. But at least he said the cardiovascular safety should no longer be the doubt, because people kept blaming sulfonylurea for cardiovascular safety for a long time, because this medical marketing knew that there's going to be no CVOT at all with sulfonylureas, and they can continue to blame it. Luckily, with Carolina, that has been removed. And this is a talk from one of our good friends, Dr. Robert Eckel, who was the president of the ADA. And it was a very nice, humorous comment that he made. He said, I have been taking patients off sulfonylurea for years. If the third party means the insurance allowed it. But this study has now helped me to know that I can continue sulfonylurea safely now. And all this came after Carolina. So I think that trial did more to a sulfonylurea, especially glimepiride, than what it did to linagliptin. Well, there is only one other point left. That's about the cost effectiveness of sulfonylureas. Well, I don't even want to go into the details and start comparing the cost, because a lot of generics has come into the Indian market. So that has kind of upset the calculation. But if you ask me as to what is more fearful than the disease, I think it is the cost of the treatment. And I face this every day with a large number of middle class people that I see. That cost can be a big burden, not of just one drug. In fact, they'll be on 3, 4, 5, 6 drugs and coming to the doctors, getting the test done. Majority of them, even the middle class, for a comprehensive care are spending anywhere between 30 to 35,000 rupees annually. And that's a lot of expenses. And in India, over 70% of the patients pay out of pocket for medicines. In fact, less than 6% of the Indian people are covered through some kind of an insurance. It can be private insurance, it can be a CGHS, or it can be probably an ESI or their own organizations paying. Even among the banks, there is a huge difference. For example, a patient coming from SBI gets the drug from his bank even after his retirement, but another person coming from Bank of India or any other bank is not entitled for this. So the rules change so much from bank to bank. Even there seems to be a problem. I think we all are moving towards patient-centric approach. The important thing is providing care that is highly respectful and responsive to individual patient preferences. If the patient says, please, I cannot afford this particular drug, but give me something which is as good or as safe, I think you can very happily prescribe a sulfonylurea today and not really worry about it. The good physician treats the disease and the great physician treats the patient who has the disease. So ladies and gentlemen, the role of sulfonylureas in type 2 diabetes continuum is something like this. You can use it in a newly diagnosed patient. Be cautious, start with a small dosage. Works the best in combination with metformin, because I always tell the audience that metformin is your derby horse. So you need a horse if you want to win the race. So metformin first, if there are no contraindication, then your add-on. It can be sulfonylurea, DPP4, SGLT2, whatever it is. You can use it in uncontrolled high HbA1c because you know the reduction can be up to 2%. Well, you can use it in overweight patients because we have seen from clinical trials that the maximum weight gain is about 1.6 to 2 kgs over 5 years. So work on the diet to make sure that this particular small weight gain of sulfonylurea is offset by your good advice of the diet. It's absolutely CV safe, so you don't have to worry about it. Carolina clearly showed hospitalization due to heart failure was higher in the linagliptin group compared to sulfonylurea, so you don't have to worry about it. And CKD, especially glycoside, is very safe, and glimepiride can also be reduced to half the dosage. Elderly patients where you have the risk of hypoglycemia, please be careful because we know that the problem exists. So if you have to use it in an elderly patient, see if you can use a very small dosage, or see if you can use a DPP4, which is not likely to give hypoglycemia. And it can be continued with insulin for long periods of time. You don't really have to take out sulfonylureas. I've continued for 18, 20, 25 years in all my patients. So the winners, we should know that they never quit, and the quitter will never win. And I take the example of great Mr. Amitabh Bachchan in this particular case because he's been a winner all along. And I think our sulfonylureas are like him. They have remained as winners for a long time, and a winner will never quit. So I don't think we should be talking about retiring sulfonylurea so very soon. If this is Mr. Sulfonylurea, he is walking out of his house quietly saying, well, I haven't not quite done roaming yet, and I will probably retire. The plan to retire. Nobody should talk about retirement at this point of time. So thank you so very much. With that, I will stop. And if there are any questions, I would love to take it. I'm sure there will be a lot of questions. People nowadays are more prone towards a DPP4. And all I say about DPP4 is, it's a double hurdle drug. That means, the GLP levels are already low. So in a type 2 diabetic, you need to have intact beta cells, intact GLP-1, and the inhibition of the DPP4 by the drug that we are using. So I clearly keep sulfonylureas much above DPP-4 when it comes to efficacy. Now the safety has been proved. Cost-wise, probably now that we have the generics, it's going to be the same, marginally less for glimepiride. I'm sure the glimepiride pharma companies are already thinking about reducing the prices further. But I think retirement is not definitely going to be around for a very, very long time. And I'm sure another decades or so, sulfonylureas will be our mainstay in the management of diabetes. Thank you.
Thank you very much, sir. There's one question in the question box. What is the correct timing to take glimepiride? Either before food or it's after food?
Yeah, see, it's generally told that just before breakfast, lunch, and dinner would be an ideal time because it needs a slightly acidic media for 100% absorption. But many have even taken it after food, and we see absolutely no difference because, I ask a patient, are you taking before food? He says, no, sir, I forgot I'm taking it after food, but mera blood sugar to normal hai na, sir. Why are you worried? So we don't have any human experiments to know what exactly happens to the absorption, but the pharmacology books say, please give it just before food, and that's the best time.
There's one more question. They're asking whether glibenclamide is yet still used or not, and if so, in which condition?
See, I started my practice in 1989, and many of my patients are on glibenclamide metformin combination, doing extremely well, and it's a good number of them. Some of them are past 70 years, and I haven't changed the drug at all because as long as you're doing good, you continue it. And interestingly, Dr. Mohan has also said the same thing. Many of his patients, even after 50 years, are taking glibenclamide metformin, but we know, hypoglycemia is going to be much higher with glibenclamide compared to glimepiride. So I'm more of a glimepiride glycoside person and very comfortable using them as.
That is the second line sulfonylureas are preferred rather than the older ones.
Yes.
The older ones had more of hypoglycemia. Olders were longer acting. And
very true. And that had to be given.
And they had their own set of problems with the cardiovascular system.
Absolutely,
so
and it had to be given half an hour before. And we did not have any data about cardiovascular safety of glibenclamide. That's one of the reasons why. And it's also not available. Many places now it's not available. And the people now write back and say, the Dianel is not available, Uglucon is not available. So
it is sold by a company in Pune, okay? It's sold by MQ.
No, some of them still have it, but the original drugs, the Dianel and Uglucon, sometimes are not available.
The thing is, glibenclamide probably has preserved its place because it's being used in some centers for GDM, gestational diabetes. I'm not sure whether South Africa still uses it, but South Africa was known to use it in pregnant women long time back.
Well, what I can remember at this point of time is I was for a short period of time in CMC Vellore, and this was way back 87. And Dr. Lily John, who was there, who actually told me that I should get into this diabetology course, was using glibenclamide left, right, and center for pregnancy. And unfortunately, it did not have a very, well-documented case studies of thousands of patients she had treated with absolutely no problems. I think you have muted, Dr. Aarti.
Yes, sir. One more question we have about C-peptide levels. Whether C-peptide levels will help detect sulfonylurea failure?
No, I think C-peptide has never been used to actually see whether drugs can be continued or not, because we do use C-peptide only to differentiate between type 1 and the other varieties. But I think C-peptide to decide what drug to use probably is not an ideal test to be done. Please don't do that. It's used only to actually make a difference with the type 1 and the other types.
Fine. Thank you very much, sir.
Thank you. Thank you so very much.
Thank you, sir. May I now request Dr. Meenakshi Deshpande, the president of IMA Pune, to felicitate you. Sir, again, it's virtual.
So I will take it like this.
Yes,
so,
sir.
You can take it in your hands like this. We are offering you.
Thank you. Thank you so very much.
Thank you for a wonderful lecture and a wonderful discussion. This
Thank
is our
you.
IMA Pune Uparna along with the bouquet.
Thank you. I humbly accept it. I will be in Pune probably on the month end for the RSSDI research meeting. I will definitely collect this separate.
Yes, sir. Definitely. Definitely.
So very much.
Thank you very much, sir.
May I now invite our quiz master. Dr. Aarti, do you want to say something before we start the quiz?
No. I have got one lecture in between. Gitanjali, you have forgotten.
Okay.
I'm supposed to finish one lecture before that.
Yeah.
Yes, I'll have to run through these slides. I hope the slides are visible. I'll just make the slide show. Is it seen or not? Just 1 minute.
Not yet seen.
Not yet. 1 minute. Just give me 1 minute's time. Now?
Yes.
Yes. Okay. Go to slideshow. I think the slideshow button. Yeah. Okay. All right. Oh, sorry. Okay. That. Here I am. I'll have to be a little faster than what I intended. This is all to all delegates because I think we are running late, right? Yeah, you people have a lot of questions regarding pharmacological approaches to diabetes management. So you have to have a systematic guideline in place. You have them, in fact, which you should be able to use. So I will run you through a few of those guidelines, which will help you choose the proper drug for the right person and at the right time. So I'll talk about shared decision making. This is what Dr. Arvind was talking about. I'll take you through ADA algorithm, AAC algorithm, NICE algorithm, ESI RSSDI algorithm. And at the end, we'll discuss a bit about take-home messages. So why do we need all these things? Why do we need so many drugs? That is because diabetes is a very complex and a chronic illness. It requires continuous medical care. And it is not just about glycemic control, but you need to go beyond that. So you need to reduce the other risk factors for reduction of mortality and complications. And we need to be aware, and we also need to make the patient aware, educate him, because ultimately these are chronic disorders which require self-management by the patients. All right. So that is why we require a lot of guidelines. We need help regarding that. So far as type 1 is concerned, it's very simple. You have to have insulin and nothing but insulin. And this insulin can be used either in the form of continuous subcutaneous insulin infusion, which we otherwise call as insulin pump, or we may resort to multiple daily injections, which are called as either bolus insulins or prandial insulins, which are taken before meal, and a basal insulin. All right. So this is all for type 1, right? But for type 2, it's an entirely different game. So I'll take you through this decision cycle, which is supposed to be patient-centered. Now, what are we actually achieving by all of this? What are the goals? So the goal is, first thing is optimize the quality of care. That is very important. And second thing is optimize the quality of life. And then you need to prevent complications. So two things. Suppose patient continues to be hyperglycemic. He has to get up and go to the loo every couple of minutes. Or suppose he is very weak. Of course, he will not be able to function. So that is not the quality of life we are looking for, right? Forward to. So we need to improve that. That is number one. Number two, you also have to look at the complications that are likely to occur. Like how we spoke about microvascular complications and macrovascular complications, the risks of which have to be reduced by various means, right? So these are two goals of care. Then how do I do it? Of course, it's just like any other patient history examination, labs, etc. But there are some key patient characteristics that I will be looking for in such patients. That is their lifestyles. Number two, whether the heart is affected in any way, that is whether heart failure or ASCVD, what we call as ASCVD stands for atherosclerotic cardiovascular disease. Okay, two important things. Then clinical characteristics like age, HbA1c, that is the present HbA1c of the patient, and the weight. And you'll have to look and see whether the patient is motivated or not. Many of our patients are not motivated, right? And of course, their accessibility and socioeconomic factors have to be thought of. So these are two important things. I stress again, kidney and the ASCVD risk, right? All right. After that, you know that say the HbA1c is say presently 10. Looking at the whole of the patient, you have to decide the target HbA1c, okay? Whether you want it to be 8, whether you want it to be 7, or you want it to be 6.5, right? So target HbA1c has to be decided upon. So if you don't have a target, you will be just going around in the gullies and not reaching the target at all. Don't do that. You'll be nowhere. You'll be here, there, everywhere. So first thing is target has to be decided. After that, you have got to see how you will be able to manage the weight of the patient, whether hypoglycemia is likely to occur and how patient would take that hypoglycemia. In sulfonylurea class, we heard a lot about hypoglycemia, okay? That was an abstract learning from that class. So you have got to do everything in your capacity to reduce such incidences, all right? So be aware about hypoglycemia episodes. So then you'll have to decide upon the medication. So for example, before that, I talked about motivation. I also would like to tell you about depression. This is known as diabetes distress, all right? It's a significant negative psychological feelings these patients carry, especially when you tell them that they are suffering from diabetes. Many of the times there comes a denial first, correct? But later on, when it dawns upon them that it is there, they actually get withdrawn and they become distressed. Of course, that is understandable because this disease makes a lot of demand on their behavioral change and they are expected to take care of themselves. And in reality, this disease progresses. Okay, so naturally, these patients are distressed. So you need to look for this distress. You might have to treat if necessary. All right. Then we were talking about HbA1c goals. Now, as we know, one size doesn't fit all. Every patient is different. So even Dr. S.R. Arvind was talking about patient-centric goals. So I'll have to decide whether I want to be lax and allow the patient to have 8% HbA1c goal. For example, in somebody who has got, say, a shortened lifespan, those who have got already ESRD, that is end-stage kidney disease, or those who are visually impaired, or those who have got, say, Parkinson's, etc. Or if it's a young, healthy, otherwise healthy man, whether I should pull it down to 6.5, correct? So the HbA1c has to be decided for that patient at that particular point of time, all right? So if the same patient whom you aimed 6.5, you might make it lax to 7 or 7.5 if patient has developed some problem, okay? So decide about HbA1c, that is very important. After you have done all that, you have got to talk to the patient, tell them about the medicines, counsel them, all right? So you did tell them that I would like you to reduce so much of weight. So give them specific goals. These are known as SMART goals. So these are the words which we have borrowed from our business management graduates, okay? So SMART goals have to be set with the patient, all right? And implement whatever management plan you have. Not just implement. You need to see whether that implementation is working for the patient or not, whether it has changed into better outcomes or not. So how do I do it? I do it by monitoring it. So when do I monitor it? I monitor it at least once in 3 months. And you might have to ask the patient to see you more frequently, especially newly detected diabetics, or in some conditions, for example, those patients who have undergone surgery or those patients whose sugars have gone up, infections, etc. All right. And at the same time, keep an eye on the patient's other problems, including the emotional and the mental health. And this whole decision cycle has to be run again, say every 6 months to 1 year. All right. So that's about the decision cycle. Now, some taxonomy you'd like to know. The drugs that we use, sometimes we use short forms. For example, metformin is metformin, of course. GLP-1 receptor agonists, they are dulaglutide, exenatide, liraglutide, lixisenatide, and the SEMA, the latest one. Okay. And then you have SGLT2 inhibitors. These are all flauzins, that is Cana, DAPA, EMPA, 2, etc. DPP4 inhibitors, there are gliptins, linagliptin. So the study that sir was talking about was done along with linagliptin. Okay, so these are gliptins, allogliptin, evagliptin, linagliptin, etc. Then you have only one TZD available, that is pioglitazone. All right, we don't have rosiglitazone anymore. It is both rosiglitazone and pioglitazone were used in diabetes prevention studies. Then when I say SU, it is sulfonylureas. So they are glimepiride, glyclazide that belong to the present generation, or the old ones like glyburide or glibenaclamide or glipizide or chlorpropamide. Then you have meglitinides, which more or less act the same way as SUs, okay, with a little difference in their action, but they have the same set of problems like SUs. It's weight gain, hypoglycemia, etc. They are the only one that is available is repaglinide, except that they are shorter acting ones. Then you have alpha glucosidase inhibitors. That is what sir was talking about, which have got an HbA1c reduction of, which bring about an HbA1c reduction of say 0.5 to 0.8. The two which are available freely are acarbose and voglibose, and of course insulin different varieties. Now this is the present ADA, that is 2022 ADA algorithm for pharmacological management, right? It appears a very busy slide. All right, we cut them into small pieces and see what we do. So what exactly is the first line therapy? Now, first line therapy will depend on the comorbidities. And as I said, patient-centered factors, including cost, access, etc. So along with the lifestyle modification, I may use, or generally metformin is used in this group, okay? But I told you to look at the patient factors. In them, I had spoken about two factors. One is whether the patient has got CKD. You have to have a serum creatinine done, converted into EGFR using different formula that are available online. You can calculate ASCVD risk factor, again, depending, you can get them on Google, Q risk and ASCVD risk factors. So you need to calculate both of them for every patient, okay? Suppose you have ASCVD risk high, or if you have CKD, that is EGFR less than 60, or if the patient already has heart failure, then you will follow the right-hand side of the algorithm, all right? So in this algorithm, I will be using certain drugs irrespective of the baseline HbA1c, all right? Remember that, irrespective of baseline HbA1c. And I may or may not use metformin, all right? I may or may not use metformin. So suppose the patient has got more cardiac risk factor, a GLP-1 receptor agonist is preferred. That is, I might use liraglutide, lixisenatide, or dulaglutide, etc. Most of them are in injectable form, except oral semaglutide, right? So it's not yet included in the study, in the algorithm, okay? So GLP-1 receptor agonists are injectable ones, the ones which have got proven cardiovascular benefits. So they are used, all right? And if they are expensive drugs, our patients cannot afford that, and nobody is ready to take an injection every day, right? So if you cannot use it, then you will have to use an SGLT2 inhibitor, all right? And if using one of them, if you're not able to get the HbA1c at the target that you have set, then you will have to use a combination, or you might use additional drugs, okay? That I will show you in the next slide. But if the patient has got heart failure, you will preferentially use SGLT2 inhibitor. And if the patient has got CKD, that is chronic renal failure, then you will see whether the patient has got albuminuria or no albuminuria. If the patient has no albuminuria, to reduce his cardiovascular risk factor, you will again treat it as an ASCVD risk factor and use a GLP-1 or SGLT2 or both sequentially, right? But if the patient has got albuminuria, it is preferable to use an SGLT2 inhibitor, right? I hope this is going good, and I hope this is clear to everybody, all right? So I have completed the right-hand corner of the algorithm, all right? So if the HbA1c has come under control, yes, the target has been met with this, then fine. But if it has not met, right, using this one drug or two drugs, then what do? Then I have to use an additional add-on therapy, all right? Or for that matter, if the patient in the beginning itself did not have either the cardiac problem or the kidney problem, then what do? I don't have to look at that part of the algorithm. I look at this part of the algorithm. So then I have to bear certain factors in mind. So what are they? Number one, in our country, I go from the other side, okay? It is the cost. Remember, diabetes is not going to go away. It is a lifetime disease. So you need to be very, very sensitive to patients' pockets. They're not very deep, right? So consider the cost and the access. Number two, you have got to look at the weight, because as sir was saying, SUs do increase weight, right? Sulfonylureas help gain weight, right? So some patients are very sensitive to that, and you also do not want the patient to become obese. So next is weight gain. Third is minimize hypoglycemia. So three things. So now how do I manage? First, come to the last one. That is, consider the cost. So in our country, what are the options? So I have used metformin, or I might not have used metformin, or metformin might not be tolerated by the patient. Then I have two options. One is sulfonylureas, that is the present ones that are available, glimepiride and the glycoside, or I use TZD, that is pioglitazone. All right. And if still the HbA1c is above the target, then I'll use the other drugs that are available. All right. Then the next is about the weight. So I would prefer to use a drug in an obese patient which will help lose weight. So which are the drugs? It is a GLP-1 receptor agonist. That is, for example, it could be liraglutide, correct? They help decrease the weight. Or SGLT2 inhibitors. Or for that matter, AGIs, that is alpha glucosidase inhibitors. Or if you cannot use any of them, or if you have used them and yet the HbA1c is not normal, you might use metformin, or you might use, say, alpha glucosidase inhibitors, or weight neutral drug like DPP-4 inhibitors. And then when you want the hypoglycemia to be minimal, for example, somebody who's known to have seizures, somebody who is very frail, correct? Or somebody who in whom hypoglycemia is not tolerated, then you will have to think about using those drugs where hypoglycemia is unlikely to occur, correct? So what are they? They are DPP-4 inhibitors, that is gliptins, GLP-1 receptor agonists, that is again liraglutide, lixisenatide, etc. Or SGLT2 inhibitors, that is all these flozins, that is it could be dapagliflozin, empagliflozin, atugliflozin, etc. Or it could be pioglitazone. Okay. Remember, if you have chosen insulin or sulfonylurea in your treatment regimen, you better use these drugs when you want to add additional drugs, because they will not increase the risk anymore of hypoglycemia. Okay, so this is something that you need to remember. So now I probably have completed both the right and the left hand side of this algorithm. But now where do I place insulin? Okay, all right, I might start using insulin in fact, or I might add insulin as either as a second drug or a third drug or a fourth drug. When patient has got ongoing catabolism, that is patient is losing weight, becoming insulinopenic, or patients have symptoms of hyperglycemia like POLIS, right? Or when the HbA1c is more than 10%, or the blood glucose levels are above 300. In that case, I usually use insulin, either as it might be the first drug, it might be the second drug, it might be third drug, or it might be my fourth drug, right? So insulin can be used in such fashion. Now, this is NICE guideline. NICE is published by United Kingdom, right? It's meant for NHS. So usually I prefer this because they are very cost sensitive people, because NHS spends on the patients. So this is better for Indian patients and us. So how do I go about it? So look at this. First, reinforce advice on diet, lifestyle. Tell them about adherence to the drug treatment. Mostly what happens, we write prescription for 15 days. Patients don't get appointment on the 16th day, they don't turn up, and the next 2-3 days when they come, they will not have taken the tablet. All right. So this is what happens to the patient. So adherence to the treatment has to be reinforced again and again in these patients. All right. And when I agree on the individualized HbA1c target, like how I've spoken, I will take into account patients' preferences, comorbidities, risks from the polypharmacy, whether how much of tight blood glucose is required, and whether I need to use something for long-term risk reduction. And wherever it is appropriate, support the person to aim for HbA1c levels in the algorithm. Okay. So if I've set it for 7.5, ask him to, motivate him to bring it down to that level. You measure HbA1c every 3 to 6 months. And suppose the patient has reached a level lower than what we had expected. Suppose it's 6.5 and I wanted it 7. Then be careful, just check why that has gone down. If it's a lady, whether she has become pregnant, etc., has to be ruled out. But otherwise, if this patient is able to achieve that lower level without developing hypoglycemia, continue the treatment. Encourage him to maintain that level. Okay. So you choose your drugs depending upon all the factors that Dr. Arvind said: efficacy, safety, tolerability, weight, hypoglycemia, etc. Okay. And you don't have to ask these patients to do home glucose monitoring very frequently unless they're on insulin, pregnant, or those patients who are likely to develop hypos again and again, or those who are operating machineries or who are driving, etc. Otherwise, they don't require it. Okay. You don't have to tell them to do it regularly or routinely for that matter. Now, this is a very beautiful slide from the NICE. This is very clear. So if you haven't understood so far, I will be able to emphasize. I have only a few minutes left. I'll complete this. So if the HbA1c is 6.5 on lifestyle intervention, more than 6.5 that is, so you offer them metformin, okay, and allow the patient to come down to 6.5. If the standard release metformin, that is the short-acting metformin, is not tolerated by the patient, then you can use either a modified release or the other metformin, which are a little more expensive than the usual short-acting or the regular metformin. And after that, suppose the patient is not able to attain the goal, and if the HbA1c is say around 7.5, hovering around 7.5, then I'll have to add another drug to that metformin. So what do? I either add DPP-4 or a pioglitazone or a sulfonylurea or an SGLT2 inhibitor. Okay. Now, as I told you, weight neutral DPP-4. If it's okay, if it's a cost is the problem, then pioglitazone or an SU, right? And patients who are obese, maybe an SGLT2 inhibitor. Patients who have got kidney problem or the ASCVD risk, SGLT2 inhibitor. No, but still the patient's HbA1c is beyond 7.5 with 2 drugs. Then what do? Then I go for what is known as triple therapy. So I have to use 3 drugs. All right. So it could be say metformin, DPP-4, SU, or metformin, pio and SU, or metformin, pio, SU, and or SGLT2. So all these combinations can be used. But remember, if I'm going to use, if the triple therapy is not effective, not tolerated, or contraindicated, okay, then you might have to use a therapy with metformin, SU, and a GLP-1 receptor agonist. Okay, so look at the change from ADA, from Americans to this, because the English people believe that GLP-1 receptors are not cost effective. Not that they're not good drugs. They are good drugs, but they are not cost effective. That is why they have brought it down the list. Okay, they have relegated it to the lower benches rather than on the higher benches. Okay, this is the change with the NICE. All right. If the patient cannot tolerate metformin, I'll have to use other drugs. So I can use any one in the beginning. So it could be DPP-4 or pio or straight away an SU. For example, pio. For example, glimepiride. So I start with a small dose. Remember, start with a low dose and you have got to upgrade it slowly. All right. These are two things that you need to remember. Start low, upgrade it or titrate it up slowly. All right. And otherwise, you can use SGLT2 inhibitors instead of DPP4, because if you want the patient to lose weight or there is a kidney problem or a ASCVD risk is high. And if first intensification is not enough, again, you will have to add another drug, that is make it a dual therapy, or if it is still not under control, a triple therapy. So this is a very, very simple one. And if I have to use if I have to use insulin in these individuals, how do I go about it? I have to use in the beginning what is known as a basal insulin. And this is usually an NPH insulin. All right. It is available. It's very cost effective. And I usually bring down the fasting levels first. And if it does not meet my HbA1c goals, then I'll have to use pre-mixed insulins or basal bolus regimens. So there are lots of variations which we'll be learning in the topic we'll cover in the next few modules. Now, this is the AACE algorithm, that is American Association of Clinical Endocrinologists. They speak in terms of monotherapy, dual, triple, the same thing which I have already explained. So they say that you usually use monotherapy if HbA1c at the beginning is less than 7.5, it's more, you start away with dual therapy. If it is up to 9, if it's more than 9, you straight away you can start with say insulin or triple therapy. Okay, so they say that you don't have to go sequentially, you start the combo immediately. Okay, this is RSSDI ESI therapeutic wheel. This is available freely on the net. This is a very, very good one, very easy to use. You might use the net, Google about how to use it. It's a very beautiful wheel, very, what should I say, user-friendly wheel. Okay. Now, all right. Is diabetes all about glycemia and glycemic control? Certainly not. We have passed that stage long back. Okay. So it is not just glycemic management. It is not just, agents which we use for cardiovascular and kidney benefit. It's beyond that. So what is it? So you have two more pillars to address to. That is management of the blood pressure and management of the lipid. This is known as 4 pillars. Okay, 4 pillars of diabetes management. So, and it rests on the lifestyle modification and diabetes education. So if your foundation of lifestyle modification and diabetes education is not good, this is going to collapse. Remember that. So reinforce that lifestyle modification time and again. And I'm sure even this slide will change in the coming years, because they have not used managing or rather screening for cancer, which Dr. Yajnik was talking about, because we see that the cancer incidences are increasing even in our Indian population, and plus we have not addressed about infection here. So these 2 pillars also will have to address in the form of cancer screening and vaccination and infection control, right? So that will be probably in the next ADA or NICE, we will be able to hear about them, more about them. As I told you, follow-up and monitoring is very important. Lifestyle, we will deal with it as time comes. This is a very beautiful slide about various drugs that we use in the management of diabetes. This is one slide which is available on the net freely. This is given by AACE, which you can use. So take home. So lifestyle modification underlies all therapy. Remember that as a foundation. That includes weight control, physical activity, nutrition, and cessation of smoking, alcohol moderation, etc. And good sleep and stress reduction. Avoid hypoglycemia, avoid weight gain, individualize all glycemic targets, whether it's A1C, FPG, PPG, because each one has got its own associated complications. Optimal A1C is of course 6.5 because it is as close to normal, but it should be achievable, it should be safe, and therapy choices should be patient-centric, and choice of the therapy will change if the patients have got high ASCVD risk or heart failure or renal status is that of CKD. comorbidities have to be managed. For example, blood pressure and lipid management. Get to the goal as soon as possible. If somebody is having 9 HbA1c, you can't wait forever to bring it down to 7, right? It should be time bound. So it has to be done as early as possible. Use affordable drugs. So patients' adherence will be better. Compliance will be better. And yes, CGM, SMBG are to be used judiciously in our patients so that their control will remain good. Okay. So on this note, I complete this topic. Any questions? I'll be free to. I will be able to. I'll be glad to take it.
Thank you, Dr. Aarti Madam. It
Yes.
was an excellent talk. If there are any questions, I'll just see into the questions.
Till then, shall we start the quiz? We can come back to the questions later.
Yes, why
Because
not?
we are running out of time.
Yes, we are welcoming Dr. Dattatray Patki. He is MBBS from MUHS and has done DNB at Pune Hospital and Research Center. And he's also guide and co-guide for DNB medicine, and he's working for intensive care. So that's great. Dr. Dattatray, he is the quiz master for today. So we can start with the quiz, Mr. Piyush.
All right, ma'am.
Yes, Mr. Piyush, if you're ready, we can start with the first question. All the delegates are ready, I guess. And I think now you all know there is a polls. You can see at the bottom of your screen, there is polls.
No, ma'am, they can't see that. The poll will directly be visible in the
Panelists.
application in front of them directly.
Yes.
So we already have the answers coming in.
Yeah.
Mr. Dattatray, please unmute yourself. Please unmute.
Dr. Datta, unmute yourself and read the question. Otherwise, I'll read it.
No,
If
he is
not ready. Yeah. Which of the following is a feature of second generation sulfonylurea? Longer half-life, more episode of hypoglycemia, more frequent drug interaction, more rapid onset of action.
Delegates will get 15 seconds to answer.
Yeah, some of these questions are intentionally asked so that we can cover all these points.
Yes. Yes.
Questions are framed such that these will be included, is already included in your lectures, so that it is easy to answer.
Yeah, some of them are not data, but then we want them to know about it.
Yes.
So
That is the main aim of this course, actually. You should learn even from questions, additional information.
Piyush, just 10 seconds, please.
Later on.
Yeah. Mr. Piyush, after 15 seconds, there should be second question coming.
All right, stopping the poll now.
Yes. Go to the next question, please. Dr. Dattatray. For the next question.
Can you
Datta,
see the
please.
question, sir?
A 45-year-old woman was brought to the emergency department by her relatives after she suffered a brief seizure-like episode. They tell you that she is taking oral medication for diabetes. On examination, patient was disoriented.
This is an incomplete question, actually.
I cannot see the
No,
complete
right?
question.
No. Yeah, I will tell. So which is the drug which the patient is likely to be on? Metformin, pioglitazone, sitagliptin, repaglinide. Her blood sugar was found to be 54.
Ma'am, do you have the question slides?
Yeah, I have the slides. I will
Will you
read them.
share
Don't
this,
worry.
because there's
Yeah, I will
another
read
long one.
Yeah, I will read the question. Don't worry.
Because if the question is very big, you know.
Yeah, I know.
There is a problem. I think
Right.
15 seconds are done. So
Yeah.
you can go to the next question, please.
The answers we will discuss at the end. Is that what you're trying to tell?
Yes.
Okay. All right. Going to question number 3. I think we will finish it off now and here itself, Gitanjali. That will be better.
No, we will be repeating the answers. He will show the poll, how many have answered correct and how many have not. So that will come after all the
time. Okay, fine, done. Okay, the next question. A 44-year-old walks into your clinic with complaints of increased hunger and thirst. On testing, was noted to have elevated blood sugar levels. Owing to the patient's financial condition, you decide to prescribe him a sulfonylurea. Glibenclamide is preferred over chlorpropamide in treatment because the latter, okay, the spelling mistake, latter is more likely to cause what? Dilutional hyponatremia, alcohol intolerance, cholestatic jaundice, all of the above. See, this is typical pharma question, and I'm sure you have answered this question when you were students. Satoskar.
Madam, will you repeat the question once again?
Okay. A 44-year-old walks into your clinic with complaints of increased hunger and thirst. On testing, she was noted to have elevated blood sugar levels. Owing to the patient's financial condition, you decide to prescribe him a sulfonylurea. Glibenclamide is preferred over chlorpropamide in the treatment because latter is more likely, that is, chlorpropamide is more likely to cause dilutional hyponatremia, alcohol intolerance, cholestatic jaundice, all of the above.
Okay, time is up. Let's go to the next question. I hope everyone has answered. Question number 4, please.
A 44-year-old male walks to your clinic with complaints of increased hunger and thirst. On testing, he was noted to have elevated blood sugar level. Owing to his patient's financial condition, you decide to prescribe him glimepiride, which acts by following mechanism: increasing peripheral utilization of glucose, reduced hepatic glucose output, act on sulfonylurea receptor 1 on pancreatic beta cell membrane, and increased transcription of genes regulating glucose metabolism.
All right, moving to next.
Yes, please.
Time is up. Next question, please.
What is the starting dose of glimepiride? First 1 milligram, second 10 milligram, third 100 milligram, fourth 50 milligram.
I think this is a very straightforward question, right? Time is up. Next question, please, Mr. Piyush.
What is the most common side effect of sulfonylurea? First, hypoglycemia. Second, hypokalemia, whether it's UTI or a pancreatitis. What is the most common side effect of sulfonylurea?
Again, I feel it is directly from the lecture, right? Yes.
Yes, yes.
So those who were attentive for the lecture would easily answer this question.
Time is up.
Let's go to the next question, please, Mr. Piyush.
A 40-year-old patient has type 2 diabetes, and which is newly detected. His HbA1c is 8.8. He has mild asthenia. His biochemistry panel is normal. Urine ketones are negative. BMI is 23. You would choose one of the following options. First, lifestyle plus metformin. Lifestyle plus metformin plus glimepiride. Lifestyle plus GLP-1 and agonist. Last one is lifestyle plus basal insulin.
This is a very good question, Dr. Dattatreya.
All right, time's up.
Yes, time's up. Next question, please.
Which of the following is not a contraindication for sulfonylureas? First is sensitivity to sulfur drugs. Second one is diabetic ketoacidosis. Third is type 1 diabetes. And fourth is type 2 diabetes. This is also straightforward. What is contraindication for sulfonylurea prescription?
Not a contraindication.
Not a
Read the
contraindication.
question carefully.
Question should be read very, very carefully. It is not a contraindication. Time's up. Next question, please.
Which of the following would be a contraindication for prescribing sulfonylurea? Type 2 diabetes, chronic alcoholic patient, hypertension, and obesity.
Madam, such questions, they give total clarity of the subject. If somebody has understood properly the previous question and this question, would clear all the doubts in the mind. It's really very, very good. Next question, please.
Which of the following drugs cause a release of endogenous insulin? Options are A. Metformin, B. Pioglitazone, C. Glipizide, D. Sitagliptin. I will read the question again. Which of the following drugs cause release of endogenous insulin? A. Metformin, B. Pioglitazone, C. Glipizide. Fourth one is sitagliptin.
Dr. Arvind sir's first slide.
Time's up.
Next, please.
Question number 11. Which of the following investigation should be done to monitor long-term glycemic control as a part of secondary prevention? Options are: first, random blood glucose; second, fasting blood glucose; third, urine sugar, and fourth one is HbA1c. I will read again. Which of the following investigation should be done to monitor long-term glycemic control as a part of secondary prevention? First option is random blood glucose. Second one is fasting blood glucose. Third one is urine sugar. Fourth one is HbA1c.
Right, time's up.
Yes, next, please.
Which of the following is a part of primary prevention of diabetes? A. Reduction of weight. Second, healthy diet. Third, stress reduction. Fourth, all of the above.
Time's
Time's
up,
up.
Mr. P. Next, please. Everyone should attempt this answering these questions. Nothing depends on this, like whether you will get MMC points
Piyush,
or not.
next one.
One should try.
Question number 13. Which of the following measures does not help to reduce diabetes complications? First option, controlling blood lipids, controlling blood pressure, eliminating all carbohydrates from diet, and fourth one is controlling blood glucose. Does not help to reduce diabetes complication. Which of the following measure does not help to reduce diabetes complication? Controlling blood lipids, controlling blood pressure, eliminating all carbohydrates from diet, controlling blood glucose.
Time's up.
Question number 14. Which of the following is not sulfonylurea but acts by similar mechanism by releasing insulin and normalizing mealtime glycemic control? First is glimepiride, second is maglitol, third is ripaglinide, and fourth one is rosiglitazone.
Time's up.
Question number 15. This is again a straightforward question. Sulfonylurea acts by following mechanism: by ATP sensitive potassium channel opening, by ATP sensitive potassium channel closing, by calcium channel opening, by calcium channel closing.
Arati madam, till then, can you check the questions in the chat box or question answers, please? Yeah, next question, please.
Question number 16. What is included in the 4 pillars of management of diabetes? First is BP, second food element, third one is weight management, fourth one is other endocrinopathies, fifth one is bone health. This is the question taken from the madam's slides, which is included in 4 pillars of diabetes management: BP, food element, weight management, other endocrinopathies, and bone health.
Time's up.
Question number 17. Metformin must be a part of initial management of diabetes irrespective of HbA1c. Whether this statement is true or false. This is again taken from the madam's lecture, which was given just now.
Time's up.
Question number 18. Goals of management of diabetes include prevention of complications of diabetes, relief of symptoms of diabetes, taking care of comorbidities, all of the above.
Time's up.
Question number 19. An old patient with type 2 diabetes of more than 10 years duration is moderately controlled, that is his HbA1c is 7.5. He is on metformin and sulfonylurea. His BMI is 24. He has albuminuria now. What will be your treatment of choice? Change the regimen and start insulin. Start metformin plus dapagliflozin. Third one is dapagliflozin alone. GLP-1 receptor agonist, liraglutide.
Time's up.
And last question. A lady recently discharged from the hospital after a cardiac intervention, has ejection fraction of 40%. Her HbA1c is 7%. Blood pressure is 120/70. Pulse rate is 74. On beta blockers, diuretics, and enalapril. Her sugar tablets were discontinued in ICU as they were found to be. I can't read the question completely.
1 minute. I'll read it for you. Wait for a minute. I'll read it. The last one, is it 20th one?
Yeah, 20th.
Okay, I'll read it. It's a bigger one. I think that is 1 minute. See, a lady recently discharged from hospital after cardiac intervention has ejection fraction of 40%. Her HbA1c is 7%. Blood pressure 120/70, pulse rate 74 on beta blockers, diuretics, enalapril. Her sugar tablets were discontinued in ICU as they were found to be normal. As her sugars were found to be normal. She was on metformin 500 milligram and glyclazide long-acting 30 milligram FDC, that is fixed drug combination, before hospitalization. So she was on glyclazide and metformin before she developed cardiac problem. So what are your plans now? She has already developed heart failure, correct? 40% ejection fraction. Insulin as she's sick. 2, metformin because she won't have lows, that is hypos. 3, empagliflozin 10 milligram as it has been found to be beneficial. D, injection liraglutide as her weight control will be better and has CV benefits. Piyush, shall we start the first one?
Yeah.
Because we have only about 17 minutes left. That is why.
Yeah, I'm just opening it in a minute.
Which of the following is second generation sulfonylureas? Which of the following is a feature of second generation sulfonylureas?
Yes.
So, second generation sulfonylurea, first generation sulfonylurea, that is chlorpropamide, tolbutamide, usually are called as first generation sulfonylureas. What we are seeing is second generation, that is glimepiride, glipizide, gliclazide, glibenclamide. So the feature of first generation sulfonylurea was having longer half-life, more episodes of hypoglycemia, more frequent drug interactions. Second generation is typically, these are more rapid onset of action, then they have lesser drug interaction, lesser chances of hypoglycemia, and lesser complications, like whatever we see with, we were used to see with first generation of sulfonylureas. So the answer of this question is more rapid onset of action.
Next one.
Yes, next one.
45-year-old woman was brought to the emergency department by her relatives after she suffered a brief seizure-like episode. They tell you that she is taking an oral medication for diabetes. On examination, patient was disoriented and blood sugar was 45 milligram per deciliter. Which of the following drug most likely to have played role in the patient's current prescription? Options were metformin, pioglitazone, sitagliptin, ripaglinate. Now here, what we are seeing that patient is 45 years, and the drugs which are being prescribed to her were metformin, which is a very bigonad, which is a very less likely to cause hypoglycemia if it is a single drug that is being used. Another one is pioglitazone, another lesser chances of getting hypoglycemia. Sitagliptin is DPP-4 inhibitors, which acts only when there is food produced in the intestine. So these are the three drugs which are less likely to cause hypoglycemia. On the contrary, ripaglinate, which is a meglinetide, which acts similar to that of sulfonylurea, it acts on the sodium ATPase receptor in the beta cells of the pancreas, thereby release of insulin occurs. And out of these four, ripaglinate is more likely to cause hypoglycemia. So the answer for this question is ripaglinate. Ripaglinate and sulfonylureas are the commonest cause of hypoglycemia when they are available in the prescription.
I think this question makes clear about the action of sulfonylureas and meglitinides.
Yeah, there is one slide I have prepared for meglitides. That meglitides are structurally different from sulfonylureas. They act on the pancreatic beta cells, act on the potassium ATPase channels, but these channels are slightly different from that of sulfonylureas. So though they act on potassium ATPase channels, but these receptors are different from that what are sulfonylureas use. They have more rapid of onset and shorter duration of action than sulfonylureas. Because of their shorter duration of action and more rapid onset of action, when they are taken with the meals, they are likely to produce postprandial lower sugars as compared to other drugs. They are administered with meals. Ripaglinate and meglitide are the available drugs. So these were a little information about meglitides.
In fact, when they market this drug, they say that no meal, no drug. So it is supposed to be an executive's or a sales marketing person's drug, so that he takes that drug only when he eats. So when he doesn't eat, then he doesn't take that drug. So that is usually what it is spoken about ripaglinate.
Yeah. So we come to the third question. 44-year-old walks into your clinic with complaints of increased hunger and thirst.
We have gone to the fourth question. We have gone to the fourth question.
Yeah.
Okay. 44-year-old male walks into your clinic with complaints of increased hunger, thirst. On testing was noted to have elevated blood sugar level. Owing to patient's financial condition, you decide to prescribe him glimepiride. So here we want to know what is the action of sulfonylurea. So options were increased peripheral utilization of glucose, reduce hepatic glucose output, act on sulfonylurea receptors on the pancreatic beta cell membrane. And fourth one is increased transcription of genes regulating glucose metabolism. So this is increased peripheral utilization of glucose is the action of metformin. So metformins usually act by increasing peripheral utilization of glucose. Also, it acts by reducing hepatic glucose. Sulfonylureas typically act on the beta cells, that they act on the sulfonylureas which are present on the beta cells. What they do, they attach to the sodium potassium ATPase pump, thereby increasing calcium influx. Calcium influx, what it causes, it releases more insulin from the sulfonyl receptor. So at any point of any amino acids or any glucose level, these sulfonylureas act on this receptor and thereby increasing the total insulin output from the pancreatic beta cells. So typically these patients act on these sulfonylurea receptors and increased transcription of genes regulating glucose metabolism. This action is seen from thiazolidinediones, that is pioglitazone and rosiglitazone. So glimepiride acts on the sulfonylurea. This is the answer of this question.
We did not discuss about question number 3.
Yes.
Piyush?
Question 3.
This is again a 44-year-old walks into your clinic, complaints of increased hunger and thirst. On testing was noted to have elevated blood sugar level. Owing to the patient's financial condition, you decide to prescribe him sulfonylurea. Glibenclamide is preferred over chlorpropamide in treatment because later is likely to cause dilutional hyponatremia, alcohol intolerance, cholestatic jaundice, all of the above. So the answer of this question is all of the above. This is typically a first generation sulfonylurea, chlorpropamide. It can cause all the side effects mentioned above, that is dilutional hyponatremia, alcohol intolerance, and cholestatic jaundice. So first generation sulfonylurea should not be used because of these side effects. On the contrary, glibenclamide does not have these side effects, hence it is chosen over the first generation sulfonylureas.
Now you go to question 5, please, Mr. Piyush.
What is the starting dose of glimepiride? Typical starting dose of glimepiride is 1 milligram. You can escalate dose up to 4 milligram, and maximum dose of glimepiride is 8 milligram. So rest of the 3 options, that is 10 milligram, 100 milligram, 50 milligram, are wrong. So the starting dose of glimepiride is 1 milligram. Next, most common side effect of sulfonylurea is, we have already learned from Dr. Arvind's lecture that sulfonylureas are prone for hypoglycemia. Less side effects like hypokalemia, UTI, pancreatitis are not seen with sulfonylureas.
So our delegates were really attentive. They have almost all have answered correct. Next, please.
7th one. This is very interesting. They should test their knowledge. That is a patient of 40-year-old, type 2 diabetes, newly detected, has HbA1c of I'm not able to see this.
8.8%. I'll read it for you. A 40-year-old has T2DM, newly detected. His HbA1c is 8.8. So almost 9. He has mild asthenia. Biochemistry panel is normal. Urine shows no ketones. His BMI is 23. You would choose one of the options. Lifestyle plus metformin, lifestyle plus metformin plus glimepiride, lifestyle plus GLP-1 agonist, lifestyle plus basal insulin. So the answer here would be B. That is because, see, lifestyle plus metformin I would have chosen if the HbA1c was lower, correct? So that would be monotherapy. I told you monotherapy you can consider if the HbA1c is up to 7 to 7.5%, correct? And you will choose a dual therapy when the HbA1c is more than 8, more than 7.5 for that matter, correct? So I will be choosing 2 drugs. So metformin plus glimepiride. Why am I not using GLP-1 agonist? That is because I have not mentioned anything about cardiovascular risk factors here. I would preferably use a GLP-1 receptor agonist if this patient had high ASCVD risk, right? In that case, irrespective of his HbA1c, whether it would be 10, whether it would be 6.5, I would still go ahead and use an GLP-1 agonist. Because I have not mentioned, that means it is not there. That is why I'm not using that drug, which is very expensive and an injectable at that, correct? This patient hardly has any symptoms. He only has mild asthenia, correct? So there is not much of a point in me starting insulin. So if I have to start insulin, the patient has to be symptomatic, insulinopenic, that means lose weight, blood sugar should be more than 300, and HbA1c should be more than 10, correct? Only then I would start using insulin as my first option. So here, and it is not a T1DM patient, not ketotic. So I'm not going to use insulin. So the answer here would be B, dual therapy, that is metformin and glimepiride. Next question, please.
Next question, which of the following is not a contraindication for sulfonylurea? So the answer for this question is not a contraindication, type 2 diabetes. Rest of the options are contraindication for sulfonylurea, that is hypersensitivity to sulfate drugs. Though many of the options like sulfate drugs are usually not mentioned in the list of the contraindication for sulfonylureas, but technically, being a sulfate drug, it should be always contraindicated to the patients who have hypersensitivity to sulfate drugs. Another contraindication is diabetic ketoacidosis, where the drug of choice is always insulin. And type 1 diabetes, again, type 1 diabetes, there is no use of drugs other than insulin. So the option for this question is type 2 diabetes. Which of the following should be would be a contraindication to prescribing sulfonylureas? Again, this is an interesting question. The answer for this patient is chronic alcoholic patient.
Piyush, please go to question 9.
Should I read again?
Just a moment. He is, yeah. Everyone, majority of have answered correct.
So basically, sulfonylureas, many of the sulfonylurea have active metabolites which is excreted via liver. If you use this in patients of alcoholism, they are usually having liver disease. There is likely to have chances of hypoglycemia and side effects related to sulfonylureas. So it should not be used in a patients with chronic alcoholism. Next, which of the following drugs cause the release of endogenous insulin? So again, endogenous insulin, sulfonylureas are the drugs which cause endogenous insulin release. They're acting on the sulfonylurea receptor located in the beta cells. So out of these, the sulfonylurea is glipizide. So the answer of this question is glipizide.
Yeah, here I would like to mention that here the release of insulin is direct, right? So it is a direct secretor GOG, what we use. This is the term which we use. There are indirect insulin secretors, and they are DPP4 inhibitors and GLP-1 receptor agonists. So we'll learn more about them when we come to it.
Next question, please, Mr. Piyush.
Which of the following investigation should be done to monitor long-term glycemic control as a part of secondary prevention? Random blood glucose level, fasting blood glucose, urine sugar, HbA1c. The easy answer, that is HbA1c. We use HbA1c goals to have check on secondary prevention of complications of diabetes. So we usually do HbA1c every 3 to 6 monthly to monitor its level, and we target HbA1c depending on the patient's age, comorbidities, as 6, 7, 6.5, depending on patient's age and patient's comorbidities. So the answer for this question is HbA1c.
Next, please, Mr. Piyush. Question 12.
Which of the following is a part of primary prevention of diabetes? This is the most easy question. Which of the following is part of primary prevention? Reduction of weight, healthy diet, stress reduction, all of the above. The answer for this question is all of the above. So primary prevention of diabetes, when patients, one should try if they have family history of diabetes. From the birth, they should always try to keep their baby's weight under control, should have a healthy diet, and always try to have lesser stress in their lives so that diabetes can be prevented.
Next question, please. Question number 13.
Which of the following measure does not help to reduce diabetes complications? controlling of blood lipids, controlling of blood pressure, controlling of eliminating all the carbohydrates from the diet, controlling blood glucose. So the answer for this question is eliminating all carbohydrates from the diet, because it is not solely that eliminating carbohydrates solely from the diet will help. That we have to reduce the carbohydrate index, cannot eliminate the carbohydrates from the diet. There should be 60% at least carbohydrates in your diet when you are managing or you are taking diabetic diet. So completely eliminating carbohydrates will not help. Also, while we are preventing the diabetic complication, control of blood pressure, control of LDL cholesterol, especially non-HDL cholesterol reduction is important, and controlling blood glucose by targeting the HbA1c level should be our aims. So this answer to this question is eliminating all carbohydrates from the diet.
That 4 pillar one has to remember.
That is next, no madam. That will come next. Which of the following is not sulfonylurea but acts by the similar mechanism by releasing insulin and normalizing mealtime glycemic control? The answer is ripaglinide. We already seen. This is again repetition. Sulfonylurea acts by which of the following? The answer for this question is ATPs by ATP sensitive potassium channel closing.
Question number 15, Piyush.
15. Question number 15, Mr. Piyush. He is discussing now the next question.
So sulfonylurea, again I repeat, sulfonylurea act on the sulfonylurea receptor located on the beta cells of the pancreas. They act on the ATP sensitive potassium channel. What they do is they close the channel, thereby increasing influx of calcium into the cells, thereby depolarizing the hyperpolarizing the membrane of the pancreatic beta cells, thereby releasing of insulin. So this is the mechanism of action of sulfonylurea. The answer is B, by ATP sensitive potassium channel closing. Now coming to 4 pillars of diabetic management. What is included? BP, food element, weight reduction, weight management, other endocrinopathies, bone health. So BP is the answer in this lifestyle modification, controlling of glucose, controlling of lipids, control of blood pressure, and diet. These are the 4 pillars in diabetic management. So the answer of this question is BP. Coming to 17 number question. Should I go ahead?
Yes, yes.
Metformin must be a part of initial management of diabetes irrespective of HbA1c. Just madam discussed before this session about the HbA1c goals and different protocols from ADA as well as NICE. So metformin must be a part of initial management of diabetes irrespective. This is false, because certain group of population we cannot start with metformin, especially those who have cardiovascular risk or kidney disease or high ASCVD risk. We go for either for SGLT2 inhibitors or DP4 inhibitors or GLP1 analogs. So metformin is not the starting for each and every patient. So they should be chosen as per patient profile.
Arti madam, would you like to throw some more light, because I think many of them have.
Yes, I don't know, because I emphasized on it many number of times. See, metformin is considered as the first line therapy, was rather considered as first line therapy till 2021. 2022, that is not the case. 2022, irrespective of HbA1c, if the patient has got either high ASCVD risk or the CKD with or without albuminuria, you use SGLT2 inhibitor or GLP1 receptor agonist or a combination of both if the HbA1c is high. All right. You might not consider metformin in these patients at all. You will consider metformin only if you want to, not otherwise. They are preferentially used in such patients. Okay. So this is 2022. This is the change. And I hope all of you have understood this point and will recall this point every time you see a patient. All right. You will be justified in starting, say, a dapagliflozin or an empagliflozin for a patient who has got EGFR of say 60 and less, or has albuminuria. And if the patient has got a Q risk or a ASCVD risk of more than say 10%, then you will start this patient on liraglutide. And maybe if the guidelines change over some time, you might be even able to use semaglutide. All right, semaglutide can be used orally, whereas the rest of them are injectables. So this is something that you need to know. So metformin actually now, like how I was speaking about sulfonylurea being retired, now next time the debate will be whether the metformin has to come down the altar, okay? Whether it has to come down the podium on which it is, pedestal on which it is placed, okay?
Next one, goals of management, 18 number, goals of management of diabetes include prevention of complication, relief of symptoms, taking care of comorbidities, all of the above. Answer is all of the above. I think we have discussed enough. So aim of any blood sugar control is to prevent complications, that is heart attack, stroke, then peripheral vascular disease. Relief of symptoms, that is whatever patients get due to hyperglycemia, that is increased frequency, then polyuria, polyphagia, as well as weight loss. These symptoms should be relieved, as well as getting relief from the complications like peripheral neuropathy. So that sugar control is very important. And at the same time, taking care of the comorbidities like diabetes, dyslipidemia is equally important. So the answer for this question is all of the above. 19 number question. An old patient with type 2 diabetes.
Mr. Piyush, please go back to question 19. Mr. Piyush, question 19 we are discussing. Yeah.
An old patient with type 2 diabetes of 10 years duration, well moderately controlled, HbA1c of 7.5, on metformin and sulfonylurea, BMI 24. He has albuminuria. What will you do? Change the regimen, start insulin, metformin plus dapagliflozin alone, GLP-1 receptor agonist. Again, this is question, as madam told just before this session, this is the typical 7.5 HbA1c. Now patient is already on metformin and sulfonylurea. He has duration of 10 years and BMI of 24. And he has albuminuria. So since he has albuminuria, the drug of choice would be dapagliflozin. So I would go for metformin. We will continue metformin. We'll add dapagliflozin to the regimen, so that it will help preventing his complications and would be a better choice than metformin sulfonylurea combination.
Question 20th, please, Mr. Piyush. Next one.
A lady recently discharged from the hospital after cardiac intervention, has ejection fraction of 40%. Her HbA1c is 7. Blood pressure is 120/70. Pulse rate of 74. On beta blockers, diuretics, and enalapril. Her sugar tablets were discontinued in ICU as they were found to be normal. She was on metformin 500 mg and gliclazide long-acting 30 mg. Fixed dose combination before hospitalization. What are your plans? So this patient is having cardiovascular compromise. She was on metformin and gliclazide combination. So this I think SGLT2 inhibitors would be a better choice for her. So empagliflozin 10 mg, and it has been found to be beneficial, would be the answer for this question. Simply because you can continue metformin plus gliclazide. But 2022 algorithm shows that these drugs like empagliflozin, SGLT2 inhibitors, have shown benefit in cardiac patients. So we would choose empagliflozin as the drug.
Yes, there was one EMPA-REG outcome study where empagliflozin was found to reduce hospitalization for heart failure and also benefit the patient from cardiovascular mortality. That is the reason all these flozins, that is SGLT2 inhibitors, have become the first drugs of choice in patients who have got heart failure. In the beginning, we thought that they are good only for those patients with heart failure who have got low ejection fraction. But over some time, we have also realized that they are good drugs even for those patients who have heart failure with preserved ejection fraction. So the moment I say heart failure, you will remember SGLT2 inhibitor. It could be empagliflozin, it could be dapagliflozin, it could be canagliflozin, or any of the new flozins that will be they will be finding that you will find in the space. But yes, the flozin should be the first drugs of choice in patients who are suffering from heart failure. That is what the algorithm said, and that is what I'm reiterating. I think we have completed the questions, and we are only a couple of minutes late today. I had one small announcement, in the sense, many of the people have said that they have not received the link. They received it very late. Piyush, please look into this and send the link the previous day itself, so that this does not happen. So that would be probably better, because many of them have not received, I suppose they have.
Even the link was said yesterday itself. The link was sent yesterday, but some people, maybe there is some issue of the email ID. That is why they have not received. So I have seen to it that the link was sent today. But again, I request all the delegates, those who did not receive the link yesterday, should inform me on WhatsApp. We send the link a day prior. So if you have not received the link till late night on the previous day, please inform me so that I can send the link again. Okay, please just inform me on WhatsApp. My
Also,
WhatsApp number is with you.
Also, ma'am, I'd like everyone to know that this link will continue for the rest of the sessions. So I hope they have this one saved somewhere so that they can join directly from this link itself.
Yes, that can also be.
Piyush, even the panelists will continue with the same link, or you will be sending me again?
Those recurring will have the same link.
Please talk loudly.
Yeah, those recurring will have the same link.
Okay, fine. Thank you very much.
And I think the links are not password protected. No? Links are specific to the emails.
The passwords are encrypted in the link itself.
Okay. So we didn't receive the password. That is what some people have, delegates have written. So
It's
there
not
is no
required.
requirement of a password as such.
No.
Okay.
Yeah, I have got some questions here. Somebody is saying I got all pharma questions wrong. I need to read in detail. You can just remember whatever we have talked today, and that should be sufficient to begin with so far as clinical practice is concerned. Somebody wants me to repeat the change in 2022. See, all these days we used to say that metformin remains the first line of therapy, but now it is not so. You need not use it in every patient. So if the patient have got cardiovascular or kidney problems, you might choose either a GLP-1 receptor agonist or SGLT2 inhibitor in place of metformin. And another question from Kamble is, starting insulin early instead of multiple drug combination, is it beneficial for the patient? Yes, of course it is. So you can start it in dual therapy, triple therapy, quadruple therapy. But remember, insulin has got a lot of problems. That is, they require a lot of SMBG, patients develop hypoglycemia, etc. So you need to be aware of that. So these are few questions which I found on the question box. So I have, and one more thing, we have uploaded some reading material for all of you. I hope that you go through all of them. After every module, some reading material will be put up on the Drive, Google Drive.
Yeah, Google Drive, and the link
So
will
access
be shared.
them and you might read them.
Yes, and everyone has to, that is why I have a Gmail. So it will be easier for them. I read out the names who had not shared their Gmails. So all those delegates should share their Gmail. Now may I request, because we have come to the end of the session. Dr. Arti, it was an excellent session. Dr. Dattatreya, thank you for excellent quiz questions. So may I request Meenakshi madam to felicitate first Dr. Dattatreya. Dr. Dattatreya, this is for you. Thank you. I would request if you can give all the explanations to questions in the PDF format, we can share with the delegates.
Yes, surely.
Yeah, Dr.
Thank you,
Dattatreya, this is for you.
Thank
And
you.
if it's possible, like if you can come down on 19th of June to Pune, we will felicitate.
Yeah, I'm in Pune only.
Hospital.
Yeah, sure.
Yeah, sure. Thank you, madam.
And this is the Upparana.
Thank you.
Yes. Dr. Arti madam, you are the backbone of this course. So may I request
At the end, all of us are felicitating you. Not
She needs 10 of such.
She's also.
Here she is.
She is also here.
Thank you.
Okay.
Okay.
Thank you, ma'am.
Thank you, Dr. Arti.
Thank you very much.
Yeah. I request all the delegates
Good.
to read, whatever is taught you should read, and we'll send the recorded link very soon. So go through the link. If there are any issues, we all are over here. You are free to send me any messages any of the day, anytime. I'll be there replying all the messages.
Yeah, and Dr. Aarti madam, there were few things that they were wanting, no use of short forms, because the short forms are not understanding. Because
That's why I wrote in the beginning itself about the short forms. I put a slide.
Please
for
request
short
the
forms.
next faculties.
Yes, what happens is over some time they will get used to it.
Correct,
That is
correct.
why I had put up one slide for that.
Okay.
I made it very clear.
Everybody requires time to copy down the short forms, no? So that was the
Yeah, but
problem.
over some time, after hearing a couple of times, they will get used to it.
Get
So
used
don't
to
worry
it.
about it.
And
See, when-
whatever is there, if somebody misses anything, there will be again a session of revision, I think.
Yes, we
Get the
will
full session of
revise.
revision.
Don't worry about it.
Yes, that is what I'm telling to all
I
delegates
see
also.
some of them said that why don't you have a didactic lecture where you study the drug, about every drug and how it works and what are the contraindications, indications, etc.
Yeah.
See, these are all what we call as adult learners. So
Okay.
if I start teaching like that, they will get bored. And not only that, while you teach a lot of things which are not necessary clinically, okay, you miss out on the bigger picture. That is,
Okay.
whatever is important is lost in the all that unnecessary thing.
So then,
sometimes we do not ask people to talk directly. For example, Arvind wanted to tell you about 2 or 3 things about sulfonylurias, which he made very clear. And what he did not, that we covered it in the quiz. Okay. So all other participants, see, we try and make it as interesting as possible.
and I think they should read the basics and come. That is also one thing.
You also need to know about a certain, what we call as benchmark studies. For example, EMPA-REG outcomes, Carolina study, Carmelina study, because there is no diabetes without these studies. So if we need to teach you from that end also. So some of the times the topic will be approached from the clinician's end. Okay. Sometimes it is approached from the pharmac side. All right. So don't worry about it. Don't worry so much about pharmacology. At the end of the day, you will learn everything that is required for you. And all those gaps in the knowledge which you think you have, please get in touch with us and we will be able to help you. And those things which we do not cover here, I will send you good reading material which will help you. Okay. So you can read it. Okay? Thank you very much.
Thank you very much. I have sent the whole program to all delegates. So they have the topics ready with them for the next session. So I hope they read and come. So that will be more easier for them to understand. Okay.
Yes.
I thank you even all the faculty and Dr. Aarti madam. And
Thank you very much. Thank you.
So next Saturday again at 2
2
p.m.
o'clock.
Yeah.
2 o'clock we meet.
Don't
Don't forget.